So my name is Didier Cheche. I'm an interventional cardiologist and I work in Clinique Pasteur, Toulouse, France. And I will let Hélène introduce herself.
So good morning, everybody. So my name is Hélène Elchaninov from Rouen Hospital. I'm also an interventional cardiologist. And we did, as you probably know, the first case in 2002 with the idea of Alain Cribier. So I'm also very pleased to conduct this trial with Didier. I think it's very ambitious. It's a randomized trial. We have to work all together with cardiologists, surgeons, nurses, because it's very strict and it's a very ambitious program. So I'm very pleased to be here, and as you said, it will be a busy day, and Didier will show you the agenda. Yes.
So thank you, Hélène. As you notice, it's a quite small room. We are all together friends. So if you have any kind of comments, any kind of thoughts you have in mind, something you would like to share, please do so, because it's really important that we gather all the thoughts, all the doubts, all the clarifications that you may need, just to make sure that you come back home with clear messages about this trial. I remember when I first met with Dan Lipis and Jana Kurucova and Martin Tones. It was 9 months ago in Marseille. And I had this idea of running a trial based on a gender-based trial, because you can see that in all the randomized trials that are available, none of them is focusing on females only. So I said maybe we could do something about that. And then, anticipating the results of the partner-free trial, it seemed that the balloon expandable platform could be a nice one to be explored in that female population. But to be honest, initially, what I had in mind was to use the Centera, because you may know that I was really a big fan of the Centera device, and I wanted to see what was the hemodynamic performance of the Centera in the female population. Centera is no longer anymore available, but we still have these extremely efficient devices that are the Sep2019 and the Sep2019 Ultra that are going to be used in that trial. So we have a dedicated population that has never been explored so far, specifically in a randomized trial. And we have devices that have to prove their performances in women, particularly the Ultra that is going to be used in this trial. So I had the opportunity to discuss with Dan Lipis, Jana, Martin, and we said, okay, let's work together. And I want to thank Edwards for accepting to fund the trial, to support the trial, and I would like to say from my behalf and Hélène, thank you for that. Then, being the PI, the next person that I wanted to approach was Hélène, because you all know that TAVI was invented in Rouen, and Hélène was the perfect person to represent females in interventional cardiology and females leading such an important trial. The best person was you, so I really thank you for accepting to be the co-PI for this trial. Thank you, Hélène. So having said that, I think it's time to move forward, and I'm going to drive you through the agenda. So you will see a couple of words from Dan Lipis, just to introduce the perception of Edwards about this trial. This is an investigator, physician-initiated trial, but the support comes from Edwards. So Dan is going to provide you a couple of words. Then we're going to see Hélène is going to drive us through the background and the rationale for the trial. We will then go through the details of the study protocol, and I'm sure you will have a lot of questions at that time, so it will be the right time to ask anything you will have in mind, just to make sure that you come with clear thoughts about the trial. So then we will have a case review from the team from Mainz about the S3 Ultra, because it's a new platform. Not all the centers have experience with that, so it's good that we could see what we can expect with the device. It would then be lunchtime, and then the second part of the day would be more about the regulatory aspects, the logistics, how to screen the patients, because we will go through a very specific pathway for the acceptance of the patient within the trial, how the core lab works, then introduction to the ECRF, and then we will have a couple of minutes to discuss anything you will have in mind at the end of the session. So, having said that, let's just review what is the overall organization. So, you have identified Hélène and myself as the co-PIs of the trial. But it's a global organization. We have Edwards with the medical affairs and the clinical affairs that accepted to support us. IPP Med is sponsoring everything, and the Triple S is going to provide all the support in terms of regulatory submissions, in terms of monitoring within the centers, but we'll go through all the details of that in the upcoming part of the day. Okay, so this is a broad overview of the organization. You will recognize many of the members that are already within the room today, so I want to thank you all these who accepted to be part of this exceptional adventure. So the COPIAs, you know them. The founder representative, Jana Kuruksova and Martin Tones. The legat sponsor, as I say, is Triple S. For the project of a size, we have Peter Bramlager here. And all the members of the steering committee, so you can see that we have quite big names because all these guys, all these ladies and men accepted to support this trial, to bring their expertise, their experience, all their knowledge to make sure that we have a successful trial that is well conducted with a good selection of the patients, with a nice interpretation of the results, but most importantly, the acquisition of a high quality level data. And this is really important. We all have to make sure that we select the right patient, we properly collect the data, and we collect all the outcomes to make sure that we capture everything. So we have Alaide Kiefo, Nicolas, my partner in Toulouse, Fabian Nitlispash, Nicolas Bonaros, that is here today, a surgeon, Bernard Prendergast from London, Maria Vassa Nicotera from Frankfurt, Philippe Pibao from Canada, and Stefan Windecker from Bern. And the core lab will be an echo core lab in Laval, run by Philippe Pibao. And we have one scientific advisor, who is Jeroen Bax. Thank you, Jeroen, for being here, from Leiden. So you can see that there is a real organization supporting the trial. It's a well-defined, well-organized trial, so we have everything set to make sure that it's successful. We also have a data safety monitoring committee with a chair that is Alec Vanian, Marco Barbanti, Peter De Jager, Lynn Van Gars, and Katja Bowman accepted to be part of it. The clinical event committee will be run by David Messica-Zetoun, who made the trip coming from Canada. Thank you, David, for being here. And his co-chair will be Rick Steeds from Birmingham. From the analysis and the reporting, all know these big names, Stuart Pocock. So just to illustrate that we have strong guys, it's a strong team. We have everything ready to support and run the trial. So overall, 440 patients are expected to be enrolled, plus or less 10% dropout. Up to 45 centers will be included. So on average, you can understand that it is going to be about 10 to 15 patients per center. And we expect 1 or optimistically 2 patients per center per month. So this is not something that is not achievable. It's realistic. So if we apply the proper selection process, we should be able to find this 1 to 2 patients per month. Okay, so these are all the sites. You can recognize the sites that you work in or you come from. 2 sites in Austria, 8 sites in France, 5 sites in Germany, 4 in Italy, 1 in Sweden, 4 in Switzerland, 1 site or soon 2 sites in the Netherlands, and 6 sites in the UK. The list is not definite. It's going to improve in the future based on the capability of the centers to enroll or not. So it's not closed. We may see additional sites in the future. Okay, I think it's time to, we're going to see a couple of words from Dan, and then I will hand over to Hélène for the rest of the session.
Hi everyone. Short message from me, welcoming you all to the Rheia Investigators meeting. Firstly, I apologize for the digital message. I wish I could be with you in person. As it turns out that the schedule has prohibited me from doing that, but I wish you a great meeting ahead. A couple of things from me. Just want to let everyone know how big of a trial this is for Edwards. It's a huge opportunity for Edwards Life Sciences, especially for the region. We have a changing landscape in Europe. There's a lot of political, economical, regulatory, environmental changes that are, I guess, affecting the competitive environment here in Europe and our competitive advantage in terms of clinical trials. And so this is a big opportunity for us to show what we can do. We've decided to collaborate on this particular project because it will not only move the guidelines forward in a meaningful way, which will affect a lot of patients in the region in a positive way, and that's the expectation. But it also will help send a big message to Edwards and also the industry about what's possible in this region when it comes to clinical trial research. Randomized trials are not going to be easy. There's no question that this one is going to be difficult because we expect a low-risk indication soon. And so it's going to be difficult. We're going to have to be really focused and really committed to deliver on what we're trying to do. The expectation, I guess, from a clinical outcomes perspective is not so different to what we've seen in the past. Although that this is an all-comers female trial, the harsh reality is that the enrollment will be more low risk in nature, and so we kind of expect more partner-like results, partner 3-like results in this particular trial. But we also get to study the Sapien-3 Ultra valve in this setting as well, and that's exciting because we're going to see what the new design of the Sapien-3 Ultra skirt does on paravalvular leak results in a legitimate setting of core lab assessment, etc. If I have one message to everyone is, please don't delegate this trial within your institutions. I really need the PIs to take a leadership role. How we do this trial, the quality of the trial in terms of patient enrollment and the cadence of enrollment in terms of, high quality imaging, complete follow-up, etc. It's going to be so important because that's what's going to give it legitimacy. That's what's going to help us to put our region on the map and enable us to move guidelines fast. So I have given the PIs and I've encouraged them and the steering committee to have complete control on how to manage this trial, and that is for success. So I just look forward to working with everybody and wishing you great success on the journey of the Rheia study. It's going to be a really big deal for our region. So thank you.
Okay, so as was said by Didier Cheche, the idea came from maybe the paucity of data concerning the difference between male and female in trials on aortic valve replacement. So before entering the details of the protocol, it's important to know what is the rationale for the trial and what do we know, what we want to know about this study. So first of all, we know, we will look at the mortality after TAVI by gender. We will first see what we have in the registries. And in the registries, we can see that from 3 registries, 3 meta-analyses, in green the men, in red the woman, that at 1 year, mortality is always lower in women than in men. So this is data from a registry, so of course today there is no randomized trial. We have also data from surgery. On this slide you see the trends from 2003 to 2014 of surgical mortality at 1 year. You see, of course, it's decreasing over years, but you can observe also that mortality is higher in female than in... This is a second observation. So I will stay here. So it's important to analyze, does the benefit of TAVI compared to surgery is higher in women than in men? First of all, this is a quite busy slide, which is a meta-analysis of early trials comparing TAVI and surgery. On the top you have the woman, on the bottom you have the men, And you can see that results are quite comparable in men, but there is a significant trend towards better results with TAVI in women from this meta-analysis with early trials. So this is already one important data. If we want to enter in the details of this meta-analysis, we have to, it's not very easy for me, we have to look at the detailed results on the top from the partner trial, on the bottom in the Corval trial. And you can observe then there is a difference between male and female. So male are here, female are here. You see that the benefit of TAVI is superior in women with a 9.2 risk difference for women compared to men where there is a 40% risk difference. And you can observe that in Corval we have the same, and it's even more significant. The risk difference for women is significant, favoring TAVI in comparison to what you can observe in men, where the difference between the two procedures is almost comparable. The results are comparable on these early trials in high-risk population. So the question is the outcome of surgery particularly poor in women, and or is the outcome of TAVI particularly good in women? So we can enter in the details looking at the 2-year mortality, again, in the Partner 1 and Partner 2 trials, so high-risk patients, intermediate risk patients, and comparing men, women, and men. And you can see that surgical mortality is quite, this is in red, is quite comparable between women and men in Partner 1. It's around 32% at 1 year. It's about 16% in Partner 2. So results, of course, have improved because we have intermediate risk population at lower risk. But when you look at the results of TAVI, you can see that in men, they are quite comparable to surgery. At the opposite, in women, results where TAVI are better, and TAVI mortality is lower in women than in the surgical group. So this is an observation coming from the 2 randomized trial using balloon expandable in low risk and intermediate risk population. Now we can go to the more recent trial, of course, the Partner 3 trial, which again compared surgery to balloon expandable valve in a low-risk population. We had, of course, both women and men, but we have 1/3 of women and 2/3 of men. And here you can observe, of course, that the mortality after TAVI is much lower than before because we have lower risk population, same for surgery. But you can observe here also that the benefit, the risk difference is higher in women than in men, knowing that TAVI outcome is comparable. So you can see that it's quite difficult to make conclusion because the results of the different trials are quite conflicting. And what we can see from the latest trial is that TAVI outcome here is comparable between men and women, and but the benefit is higher for women than for men. So it's most likely, but it's not proven, that the benefit of TAVI compared to surgery is higher in women than in men. So this is a question which is not solved and which remains to be evaluated. And we have to try to understand why, and it's difficult to know exactly what are the reasons for this difference in risk-benefit between men and women. What we can see from this meta-analysis on acute peri-procedural complications of TAVI versus surgery, we can observe that the risk of stroke or the risk of major vascular bleeding is quite comparable, but we have less major bleeding in women favoring TAVI. So we observe at least one difference in this kind of these acute complications. Concerning the other complication we have after TAVI, pacemaker, MI, moderate AR, there is no difference. There is a trend toward less renal insufficiency in women favoring TAVI. But we have different questions which are unsolved. If we go back to surgery, we know also that there is a difference between TAVI and surgery according to the annulus size, because in the early trials, you remember, there was a difference in mortality in small annulus, because we know that the mismatch can be more frequent after surgery than after TAVI in patients with small annulus. So this could explain at that time the differences. We know also, but we don't have the detailed result, that in partner 3 this difference is less, because the surgeons did better work to try to adapt the size and to use larger size in women. But still, it's a question which remains to be approved. So in summary, it's quite difficult to have a real clear conclusion about the difference between women and men after aortic valve replacement. What we can say that there is probably a reduction in the risk of death for women versus men in patients undergoing TAVI, and there is an increased risk of death for women having surgery. But we know also that there are substantial differences in baseline and procedural characteristics between men and women, which are not eliminated by randomization, meaning that we need a randomized trial to confirm this observation of the higher benefit of TAVR over surgery in women. But also we know that it's something which has been discussed several times, and you can see here that Adelaide, who is not here today, said also recently that we need a randomized trial in this specific category of the population, the women. We know also it's very complicated, and that's why I just want to make fun, show you this slide. I will not enter in the details, just to say it's very complicated to try to understand why and what are the difference between male and female after aortic replacement, if either percutaneous or surgical, and this emphasizes the need for the randomized trial we will talk about today. Thank you.
So thank you, Hélène.
So,
now, I guess your slide, if you come back, is very important, because it really highlights all the difficulties of treating women from a surgical but also an interventional perspective. So it could be the right time just to try to gather some experience from the audience here and to understand in your practice, what have you identified as risk factors explaining such a difference between men and women when they undergo, for example, surgery. Let's take the opportunity of having a couple of surgeons here. So maybe Nikolaus, how do you explain that difference? Why are women so exposed to more complications when they undergo surgery?
Thanks, Didier. I think the most important thing, at least from our experience, is the small aortic annulus. And this is, and I really give you credit for this idea, because the small aortic annulus is something that affects the results of surgery. And we know, of course, it's all about size matters. We know that. The problem we have with the annuli in females is that we are obliged to insert small aortic valves, and we have problems with postoperative gradients, et cetera, et cetera. There are ways to address it from the surgical point of view. There are some surgeons here. There are ways to address it. There has been previously some efforts to use stentless valves, but this is gone. We have learned that. There are now nowadays some issues to use sutureless valves. They may have a benefit on that. And there are some complex operative procedures of annulus enlargement which allow us to achieve better results. But again, it is the problem of complexity, could bring some problems in comorbidities and mortality and morbidities after the procedure. So I think this is for me the main message, the annulus.
Okay, thank you. So we understand that there are many ways from a surgical perspective to try to get the bigger valve size inside the patient, but this creates a higher risk of peri-procedural complications because you have lengthier procedures. And you discussed but if we come back to the partner 3, maybe they applied these techniques because they had exceptional results from the surgical arm as compared to what we saw in the past. So maybe this is a kind of message that we can all share. For the surgical teams, maybe it would be very important to apply these techniques, even if they are more demanding, more challenging, just to make sure that we get good results in the surgical arm and we don't artificially promote TAVI in that trial, very important trial. I'm an interventional cardiologist, so I'm going to push more for TAVI, but we have to make sure that the surgeons do a good job.
Just to comment on that, this is a reason why we have accepted all kinds of surgical techniques and all kinds of valves, even the new generation of sutureless valves. So every surgeon can feel free and insert the valves that they use at this study. So it was excluded, sutureless valves were excluded at the partner 3. And if you take a look at the partner 3, the majority of the valves were from a specific fabric. So we will have a huge variation at this European study.
So any experience with sutureless valves here in the audience? Who is a surgeon? Please raise your hand. So many experience. So what is your feeling? Because from, I don't know what is your experience, Hélène, with sutureless valve, but we had to treat quite early failure of these valves. So do you think that, we said, because Nikolaus is part of the steering committee, we said we're going to allow the use of sutureless valve. So are there specific things we need to know just to make sure that we use the correct valve for the patients?
I think one of the problems might be that we have more paravalvular leakages, what we never have with normal surgical valves. So this is one of the downsides using a sutureless valve. We didn't see any early failures in our center, so I don't know if it is a problem in other centers or not.
Do you have a special technique or a special type of valve?
No, not really.
So I saw that there were lots of surgeons here. Any comment from another colleague? No? This side?
Hi, Augusto D'Onofrio from Padova, Italy. Well, I understand that including all kind of procedures and of kind of valve might be something, a good opportunity for this trial, but I also believe that might be a little bit confounding because, you know, there are a lot of centers that may use different kind of surgical valves, and we all know that there are very well-performing surgical valves in terms of hemodynamics, and there are other valves that are not so well-performing, and also there are surgeons that enlarge the annulus and surgeons that don't enlarge the annulus. So we are comparing the best TAVI valve we have, probably, with a lot of different valves and a lot of different procedures, and probably this is quite a big bias. So I don't know how you want to... In this kind of patients, we normally use the sutureless valves, the intuitive valve that open and enlarge the LVOT. And in our experience, these kind of valves have very low gradients, almost comparable to TAVI. And so this is what we usually do in our practice, but we do, and I don't know if other centers do, or probably there are other centers that use centreless valve or enlarge the annulus. So, you know, it's a kind of confusion, and I don't know when we analyze this data what's going on. So I don't know how you want to overcome this problem.
So I think this is a very important comment. We're going to see that all types of surgical valves are allowed, all techniques are allowed, but it's really important that in a dedicated center, you select the appropriate technique, the one that you master, the device that you master to make sure that you're going to get the lowest gradient achievable for the specific patient. So it's really important. We don't have any data to support a special technique as compared to another one from a surgical perspective. So let's say that this is current care, this is standard of care in a contemporary practice. We can use all techniques as far as you master that technique, and you're not going to generate some bias based on the learning curve that you're going to require for a new technique. So use the technique that you regularly use in your daily practice, the device that you use, everything is allowed. We've heard a lot about the sutureless valve. I don't have any experience, major experience with that, but this is an opportunity. We're going to have a cluster of patients with these types of valves, so maybe we're going to be able to provide additional data apart from the main primary endpoint, additional data about these surgical valves also. So this is a huge opportunity that we have. Maybe in the second part of the trial, the analysis of the data to compare surgical techniques, surgical valves, and so on. Do you have any comment, Hélène?
No, I think that, as you said, the more important for the surgical side is to do the best you can to have the largest area in this special population of women, and in particular when they are small. So probably, I don't know if a center has 5 to 10 cases, because the other one will be randomized to TAVI. I don't know if probably it's important to select the surgeon who will do the best, who will have the largest experience, for example, for enlargement. If they want to use enlargement, probably all the efforts have to be made to obtain the optimal results, of course.
One comment to the of our colleague. We don't have European data, but if you look at the American data, the percentage of patients who get an annular enlargement in the STA-STAT database is below 3%. So if we conclude to our patient population, if we include, for example, 10 patients, 20 patients, 10 of them will be surgical, so the amount of patients who will get an annular enlargement would be probably 0.3. So it's not that common.
Thank you.
I just wanted to make a little comment. Obviously, all this data that you presented is not randomized sex differences within trials, is that correct? That's why we're doing this trial. And going away a bit from the procedural technical differences, look at the patient. I mean, the patient are randomized, and there are lots of factors that are not being randomized, like women are usually older, they have more high-risk factors like more chest irradiation for breast cancer, more osteoporosis with kyphoscoliosis. They're different type of patients than men. They're high risk for different, or medium risk for different reasons. And that might be the reasons why they are getting different results.
I think you're perfectly right. There are specific factors related to women that we didn't really capture in these trials. If we come back to the first, and one thing that struck me when I read the results of the partner 3, and Hélène has demonstrated that, is that initially when we take the high risk or intermediate risk trials, we had 2/3 of women. So women were really driving the results of these trials. And in the partner 3, it was the exact opposite, 2/3 or to 70% of male. So we now accept the fact that TAVI is a very good technique, could be the first choice technique for low-risk patients if the transfemoral access is favorable. But the results we have mainly relates to men. And this was new. And this really provides power to the trial, to the Rheia trial, because it's going to explore only in women the outcomes that we have, and we're going to capture all these differences that are inherent to women in this trial. So it's a very important trial. And so if you agree, maybe we can go through the protocol now.
Can we have a technical break so that we connect to one more microphone?
Yeah, sure.
Just two or 5 minutes.
Merci.
Thank you.
And we were saying that we're going to use different types of surgical valves and many techniques from the surgical aspect, but also in the transcatheter arm of the trial, we will have 2 different platforms. It's not going to be one valve for all types of patients. We're going to use the S3, but also the S3 Ultra. So these are slightly different devices, and we're going to be able to not really compare these TAVI devices, but to get information about how S3 performs in women, how S3 Ultra also performs in women. We're going to see that afterwards in the, I guess, in the cases. But just in the meanwhile, solving the technical issue. In the trial, we're going to use the S3 Ultra with the Commander platform, the Commander delivery catheter, because you are maybe aware about technical issues with the balloon of the Ultra platform. So we're going to use the combination of the S3 or S3 Ultra plus the former Commander catheter that we all know, we are all used to utilize in our daily practice. So this is really to make sure that we don't integrate new bias within the trial. We use, as the surgeons are going to do in the interventional arm, the best techniques for the patient, and we're going to compare apples with apples. So this was just a precision I wanted to provide to you. So in terms of, we said, Hélène said that maybe it could be important to have maybe not a dedicated surgeon to perform all the procedures, but in your centers it could be very important to identify a couple of surgeons that are going to treat all the patients, to make sure that they are going to apply the same techniques to the patients. They are going to really focus all the care required to these patients to make sure that the outcomes are the best achievable for a dedicated patient. So maybe having 5 surgeons treating one single patient or 2 patients within the trial is not the best way to do so. Maybe a couple of surgeons taking care of all the patients. This may be an internal solution that you may apply in your institution. So just to emphasize the fact that you need to discuss as local health teams about who is going to do what, who is going to screen, who is going to send the data for the evaluation of eligibility, who is going to gather and collect all the data from the patients, particularly in the surgical department. It's more a regular practice in the interventional cardiology department. You have to organize yourselves just to make sure that for these 10 to 20 patients that you're going to treat, we collect everything in a proper way with the appropriate echo views, appropriate loops. All the data are collected in a quite thorough way, and this is really mandatory because we all have a kind of duty, we have a responsibility, as it is the first trial of this kind in Europe for many years. US is going to watch us because one of the feelings that they have is that we are not able as Europeans to gather high quality data. So let's show that we can achieve that. We are all experienced, we know how to run trials, but let's all together demonstrate that we can achieve a very high level quality data collection. Okay, so this is just for the protocol. We're going to go through all the details of the protocol. Many questions are going to raise in your mind. Please feel free to interrupt whenever you want, and we have plenty of time to discuss that. So very important, the inclusion criteria from the trial. You can see that the inclusion criteria are quite broad. So we want to include as many women, as many female as we can. So we have the regular definition of aortic stenosis. The basis, we want to include only symptomatic aortic stenosis patients. Only symptomatic aortic stenosis ladies. So these are the standard definition with the jet velocity above 4 meters per second or a mid gradient above 40. With a valve area below 1 or indexed below 0.6 centimeters square per meter square. Or, and this is quite new, we're going to include the low gradient severe AS, and this provides all the another interest to the trial because most of the time this subset of patients was excluded from the randomized trial. So we allowed the inclusion of low gradient severe AS as defined as follows. And I had that discussion with David Messika-Zetoun about the calcium score. Calcium score is required to make sure that the patient has a significant aortic stenosis with a low gradient, more than 1,200 Hounsfield unit for the ladies. So it tells us that we need to acquire a CT scan for the patient at baseline, even for the patients that are theoretically surgical candidates, just to make sure that we have a proper assessment and we're going to detect and include this cluster of low gradient severe AS patients. So we have clear definitions, and this is new. This type of patient is going to be included. So the patient has to be symptomatic, at least in NYHA class 2. The other symptoms are allowed for sure. And if the patient is not really symptomatic, we require an exercise, a test that demonstrates a limited exercise capacity or an abnormal rise distribution of the blood pressure or even arrhythmia during effort. So assessment of the patient at baseline is really important. If you have a patient who had a previous transthoracic echo, you think that it's a good candidate, just make sure that all the criteria are met, particularly if you have a low gradient AS and or a patient that is not highly symptomatic. Make sure that you have everything, bring back the patient, repeat the testing, CT scan or exercise testing if required. So the exclusion criteria, we have a quite broad list of exclusion criteria. You're going to get all these items, but these are quite logical ones. We want to make sure that we don't integrate factors that are going to generate some noise when it will be time to interpret the outcomes. So we want to make sure that the patient has a suitable anatomy for the available for the study device. So that tells us that CT scan, once again, is mandatory for the screening process. Every patient needs a CT scan, and we have to make sure that the annulus is in the range of a 20, 23, 26, 26 S3 or S3 Ultra, or 29 S3. The 29 will be the S3. There is no 29 S3 Ultra. So the vessels have to be compatible with adequate transfemoral access for the introducer, whether it be the 14 French or the 16 French E-sheath. Acute myocardial infarction within 30 days. Bicuspid or unicuspid valves are not the focus of the trial. Maybe we will run, if you want, if somebody has the idea in the future, we will need a dedicated trial on bicuspid patients, but this is another topic. So we exclude bicuspid patients from this trial. Severe aortic regurgitation is excluded, but most of the time, if you have an extremely calcified valve that is regurgitant, based on the echo analysis, we may accept the patient or not. But if you have pure severe aortic regurgitation, the patient is excluded from the trial. Any concomitant severe valve disease that requires an intervention will be excluded. We don't want to get two surgical valve procedures at the same time because it's not the focus of the trial. Any valve prosthetic substitute in any position. If the patient has a complex coronary artery disease, we're going to exclude the patient. So we have to make sure that the syntax score is below 33, that we don't have any unprotected left main, and that the heart team agrees that syntax score below 32, no left main, we can achieve a good PCI for the patient just before or during the procedure. So coronary angiogram is required for eligibility of the patients. And we will make sure that the syntax score remains below 32 and we don't have any unprotected left main. Once again, to be sure that we focus on the valve, on the woman, and we don't integrate over bias to the trial. So if we have a peripheral disease, particularly at the level of the carotid of the vertebral arteries that may promote some stroke and generate some stroke, the patients are going to be excluded. Blood disorders, these are the regular definitions, you know that. In unstable patients, patients with mechanical ventilation, mechanical support are going to be excluded. If you have highly severe septal hypertrophy with an obstructive cardiomyopathy, the patients are not going to be included in the trial. LVEF, and this is quite important because we may see this low flow, low gradient AS with depressed ejection fraction. The threshold is 30%. So the LVEF has to be above 30% to be accepted in the trial. Any evidence of thrombus, intracardiac mass, vegetation, endocarditis, for sure the patients are going to be excluded. It makes sense. If the patient has any contraindication to antiplatelet or antithrombotic treatment is going to be excluded. And for stroke, we require that the occurrence is above 90 days before randomization. So these are the regular exclusion criteria that we all know and we see in all the trials, registries that we've run. Severe renal failure and active endocarditis, FEV1 below 50% for the lung function. Pulmonary hypertension, and this is something that is new. We don't have a dedicated number, but we exclude the patient with a pulmonary arterial systolic pressure that is above 2/3 of the arterial systolic pressure. Cirrhosis or active liver disease are going to be excluded. Peripheral disease at the level of the abdominal aorta and so on are going to be excluded. Patients with hostile chest are going to be excluded. This is for the surgical arm. So these are not regular TAVI candidates. Ideally, what we expect is to enroll more of low-risk patients in this population. So the patients need to be suitable candidates for any conventional surgery. Really obese patients, more than 50 kilograms per meter square of BMI. The patients in poor conditions with a life expectancy below 2 years are going to be excluded. So this is a subjective estimation, but you have to honestly assess that just to make sure that the patient is going to live at least 1 year, and we're going to have an outcome at 1 year because the primary endpoint is at 1 year. So these are not regular TAVI candidates. If it is an inoperable patient, high-risk patient, maybe this is not the right type of patient to include in this trial. Okay, and pregnancy, normally it shouldn't be an issue in our population. But I'm saying that, but I've already been contacted by a patient, a lady who is 44 years old, just to be enrolled in the trial, and Adeline can assess that. And this is something that we may face, so this is one of the exclusion criteria. Okay, so overall, as we said, we're gonna include 440 females here within the trial. You make sure that the patient fulfills the inclusion and the exclusion criteria, so this is your duty. We're going to assess that during the monitoring, but we want to avoid any deviation to the study protocol. So just pay attention to the inclusion-exclusion criteria when you select a patient, when you screen a patient, just to make sure that we have everything. So transthoracic echo with recorded loops is mandatory. CT scan is mandatory. If you have a low flow, low gradient AS patient or an asymptomatic AS patient, go for a stress testing before submitting your patient. So you have to collect all this testing before sending your screening slides to the steering committee. Once you get that, you have to consent the patient first, and then you send the images, the slide deck that we're going to discuss in the second part of the day, the screening slides to the steering committee, and within 2 days, 48 hours, you will get an answer whether or not your patients can be randomized. So within 2 days. So this is going to be a fast review process just to make sure that everybody can treat his patient in a very flexible way. So it's going to be a one-to-one randomization between TAVI and surgery, TAVI, PCI, surgery, CABG, syntax score below 32, no unprotected left main, but one-to-one randomization. And then after the procedure, we will have a post-procedure assessment 48 to 72 hours. Assessment at discharge, these two can be combined based on the discharge day of the patient. So this is something that we can simplify. If the patient is discharged at 2 or 3 days, you can combine both. So then we will have a 30 days follow-up, 6 months follow-up, and the primary endpoint will be at 1 year. And we're gonna describe the primary endpoint afterwards. So this is a sequence that is important to keep in mind. So you have a patient that is eligible. You need to make sure that the patient is really eligible. Consent the patient. You send the patient for screening eligibility by the steering committee. You get the answer within 2 days, 48 hours. You can randomize the patients, but from the consent to the treatment, the window is 30 days. So you have 30 days to consent and treat your patients. So this is very important, otherwise we're going to integrate study protocol deviations. So 30 days is a quite large window, and you will have at least 28 days, because you send you screen the patient, you consent the patient, you send the images, we accept the patient, you can randomize, and then you have, after these 2 days period, you still have 28 days to treat the patient. So it's a quite comfortable window for doing that. Then, as I said, the first assessment post-procedure at 2 to 3 days, a discharge, some safety endpoints, at 30 days, plus or minus 10 days. Over 8 points are going to be assessed. At 6 months, it's going to be it could be a phone call. If you want to bring back the patients for assessment, you can do so, but a phone call is allowed. And then the primary endpoint, the most important, would be at 1 year. So what is that primary endpoint? It's based on the partner-free definition, and it combines exactly the same items as partner-free. And just to remind you that every single item was significant in that trial. So this is not a combination just to make sure that we artificially promote TAVI or so on. This is based on the available outcomes in the literature. The so-called all-cause mortality, all stroke, disabling and non-disabling, and rehospitalization, valve-related, procedure-related of worsening of congestive heart failure. So this is the composite primary endpoint that is going to be assessed at 1 year. So for the sample size calculation, everything was based on the partner-free trial, and we end up by estimating the event rate of 16% within the SAVR, the surgical arm, and 8% within the TAVI arm. If you remember in the partner, it was about 8.1 to 8.5% in male and female. And so overall, we estimated that 440 patients could be enough, accounting for withdrawals and so on, loss of follow-ups, to make sure that we have the appropriate power to identify a difference between both treatment arms. Everything is based, all the definitions are based on the VARC2 consensus document that you know. For those who are not really familiar with that, this is the type of definition that we use for every single registry or randomized trial that has been run since 2013, and the first descriptions of these definitions. We had previously the VARC1, but VARC2 is the set of definitions that we use in daily practice now. So just to illustrate that disabling stroke is going to be part of one of the endpoints, as will be non-disabling stroke. But it's not a matter of feeling, saying, oh, the patient has a disabling or a non-disabling stroke. This is based on a true definition, on a true assessment. And the most important thing is to do a modified ranking score from baseline and then post-procedure and then at 90 days to make sure that the patient didn't experience stroke, or if the patient has stroke, this is a non-disabling or a disabling stroke. So we have a clear definition on that. And this is extremely important. So that MRS should be assessed by a qualified person according to a certification process. So you may already have in your center somebody who is dedicated to the MRS assessment with a valid certificate. If it's not the case, you will need to identify a couple of persons. It's not necessarily a neurologist in your department, but it could be a surgeon, it could be an interventional cardiology, a study nurse, a research coordinator from another type. It doesn't matter, but that person needs to be certified. So you will need to, once you go back home, to try to understand if you already have somebody like that who is certified. If not, if it's not the case, it's an online certification, so don't be afraid. It's not something that is not achievable. There is a dedicated website. You go there, you follow the training, 1 hour training, and then you get your certificate that is valid something like two years or something like that. So it's not something that is not achievable. But this is mandatory just to make sure that we collect the appropriate outcomes, we all talk the same language, and we do the things in the right way. It's not a registry, it's a randomized trial. It's something that is really important for the patients, really important for us as a medical community to prove that we can achieve a very good randomized trial. So you need to make sure that you have this type of persons who is going to do the MRS assessment in your center. Do we have a certificate? If not, go. You will send the links, you go online, you do your certification process, and then you are set for the whole duration of the study. And maybe something that is quite important is just to make sure that the same persons assess the patients from baseline and then follow up, just to make sure that you capture the small, the subtle changes in the status of the patient. Okay, so just, so the MRS, you have from 0 to 6. The higher the score is, the more disabling is the stroke, 6 being death of the patient. So we have a really specific assessment of the patient. It doesn't take a lot of time, but we have to go through that process, and it has to be done by certified people in a dedicated center. So apart from the primary endpoint, we will assess some efficacy and safety endpoints, the length of hospitalization after the index procedure. As Nikolaos and other surgical colleagues have discussed, the occurrence of moderate or moderate to severe patient prosthesis mismatch at 1 month, new onset atrial fibrillation at 1 month and 1 year, because this is something we need to understand, because it may impact the treatment of the patients in the future. Maybe women have more susceptibility to develop atrial fibrillation post-TAVI or surgery. We don't really know that, and we're going to see that in that trial. Major vascular complication at 30 days and 1 year, because Hélène just pictured that in the previous slides. It seems that we have more major vascular complications in women after TAVI than in male. We're going to see if with these new platforms it's still the case. We all have experience. It's a mature procedure in Europe. We're going to see if we can achieve low rates of vascular complications in that female population. Bleeding is really an issue with ladies, particularly post-surgery. So we're going to see if life-threatening, disabling, major bleeding at 30 days and 1 year is an issue, is still an issue in that female-focused randomized trial. Acute myocardial infarction, 30 days and 1 year, and acute kidney injury, stage 2 to 3, according to the Aiken classification. It's the one that is used, that is promoted by the VARC2 consensus. So it's a specific assessment. And this is, we're not going to go through the details, but just to tell you that it's a combination of the rise, the difference, the progression of the creatinine level, the decrease of the urine output, and so on. And then we can classify the patient between stage 1, 2, 3. And we're going to focus on the most aggressive complications, stage 2 and 3 acute kidney injury for our patients. Okay, so as usual, just to illustrate that we're going to collect every kind of the most frequent complications in this population, and if you have in the future ideas about studies you want to run after the publication of the primary endpoint, you can start to think about this, and we can discuss that during the steering committee meetings to see how we can anticipate the things for the future. So new permanent pacemaker frequency will be assessed at 30 days and 1 year. The functional status of the patient, the hemodynamic valve performance for sure, the cognitive function, and I do believe that this is something that is quite important because it may highlight a real difference between surgery and TAVI in terms of cognitive decline, because we may treat in the future a low risk, lower and younger patients, and we have to make sure that we don't damage the brain for this patient. If you want, we may discuss the use of cerebral protection devices. This is something that is quite open, and if you want, we can discuss that afterwards. And frailty is going to be assessed at 30 days and 1 year. So from the cognitive function, once again, the identified person in charge of exploring the brain disorders in the patient will need to go through all these 3 assessments. So it's a quite demanding, but it doesn't require such a long time if you get used to that. So that's why it should be the same person. First, running these tests, and second, exploring the patient from baseline to the study timelines. So the MMSE, we're not going to use the regular version in which you make the patient draw and so on, count backwards and so on, because it's too lengthy. We're going to use the MMSE2 that it only takes 5 minutes in the brief version to assess. So, but this is going to be compared from baseline to the study timelines. So it's going to be important that you get used to that you know how to run that within 5 minutes, and you repeat that in the same way. The NIHSS, you all know that. This is very simple to use. You have a 15 item scale, and most of the time it takes 5 to 10 minutes to achieve. The MRS, we already talked about that, so it's going to be a combination based on the timeline, whether it be at baseline, 30 days, 1 year. The combination is going to be variable, but you will have to become familiar with these 3 testings. Frailty is a little bit more challenging. It has to be assessed at baseline. We have the blood assessment with the albumin, for example, and we have these regular items. Maybe you are used to that, the CATS score for the independence of the patient in daily activities, the grip strength, the 5 meter work time, the albumin level. So this will be combined to assess the frailty of the patient. But as we aim to include mostly low-risk patients, we shouldn't see so many frail patients, but we will see. Frailty is not an exclusion criteria. And then at last, quality of life. Quality of life. We try to take the same items that were explored in the randomized trial, in the partner-free trial, and even the low-risk trial. And this is the Kansas City Quality of Life Questionnaire. It's a little bit lengthy, but we will have to do that, and the SF12. And this will be assessed at 30 days and 1 year. So not at every single visit, but we will have to do so. And this, once again, can be assessed by not the surgeon or the interventional cardiologist, but you have to identify a dedicated person that is going to run the frailty tests and the quality of life assessment. So it's just a matter of organization, determining who is going to do what at which timeline, and just to make sure that you get the things in the proper way. One single person cannot do everything, so you need to be organized as a team in your center. So we now come to more busy slides, but it's a kind of summary of what we're going to assess from baseline to 1 year. So you see at baseline the functional status of the patient, physical assessment, and as usual, the neurological assessment at baseline, the MMSE2. All 3 testings will be assessed at baseline and the risk scores as usual. At the time of procedure, but most importantly post-procedure and or at discharge, you will need to reassess the cognitive, the neurological and cognitive function of the patient by these testings. Laboratory investigations. Pregnancy test, okay, we'll see. Depends on the patient, but these are standard of care. Maybe the albumin is not really, albumin and bilirubin are not standard of care in your practice. Just make sure that for the Rheia trial, you create a protocol in which every single patient gets all of these testings at baseline, just to avoid missing data and bias within the study protocol. For the non-invasive test, invasive test, the ECG, a transthoracic echo, the pulmonary function, and also the quality of life questionnaire. What is going to be repeated is the ECG and the echo at discharge, at 2 to 3 days, and or at discharge. But once again, both timelines can be combined within a single debate depending on the discharge period of the patient. So this is, to my opinion, very important. And once again, just to emphasize on what we require: CT scan, TTE, so a cardiac catheterization with the coronary assessment, because we know, you understand now that coronary disease that is extensive is part of the exclusion criteria. Assessment of the medication of the patient. Make sure that you get an informed consent of the patient, and then you only once you have everything, you send the patient for case review. Let's say it's going to be day 0, day 2, and then you get the green light for randomization. So if you do so, we don't expect dropout, high level of dropout, but it's going to be based mainly on your screening efficiency. And this is something that we really cannot influence, but if we can help you in any way, come back to us and we can try to identify some solutions just to make sure that you get all the testings before submitting your patients. So this is quite redundant, but you will get everything clarified. You have it in the booklet, so we're going to go quite fast now. About the anti-thrombotic treatment, this is something that we discussed within the steering committee. It's not mandatory. This is only a recommendation. So you do as you do usually in your daily practice. But if you need a guidance, this is what we said we will try to promote for the Rheia trial. So aspirin should be continued. If the patient is under clopidogrel, for example, after PCI, if it's a BMS, it's not really easy to see. If the patient is randomized in the surgical arm, clopidogrel can be discontinued after 1 month post-BMS or 3 months post-DES. So this is just to provide the guidance. If you want to operate the patient under the combination of aspirin and clopidogrel, you can do so, but this may artificially increase the risk of bleeding. Bleeding is one of the outcomes that is assessed within the trial. So just to make sure that we don't integrate artificial bias that could be prevented by just waiting a couple of months, 1 to 3 months before treating the patients. So if you have to wait, don't consent the patient immediately because we need 30 days between the consent and the treatment. So wait, and once the patient is not anymore under clopidogrel, you can consent him, consent her, and send the data to the screening committee. So for VKA, in case of atrial fibrillation, what we recommend is to bridge everything to a low molecular weight heparin or unfractionated heparin prior to the implant based on your local practice. We don't recommend to treat the patients under VKA. We do it for TAVI as a routine practice, for example, in Toulouse, but we're going to switch for the trial just to make sure that we all treat the patients more or less in the same way. And then if you have intraprocedural thrombus detection, this is a standard of care and it makes sense. You just have to make sure that you provide additional heparin to the patient and you make sure that you have an ACT that is adequate. And it's up to you to abort the procedure if needed. Okay, this is this is one of the final slides, and it's quite important about the steady device handling. So as I said, we have 4 valve sizes: 23, 26, 3 valve sizes. Sorry, 23, 26, 29. The 23 and 26 are going to be either S3 or S3 Ultra. The 29 is going to remain the S3, the regular S3 as we all know. We won't use the S3 Ultra 29 that is not available for the trial. So what you're going to do is to take the device that you have on the shelf available at your institution. You document the serial number, the kit number of the device you're going to use for the particular patient, implant the valve, and then Edwards will not invoice your hospital for the device that you have used for the patient. So this is something that is quite new. For some countries, Ultra is not available, as for example in France, so we're going to start with the S3, and as soon as the Ultra becomes available, we're going to use the Ultra. So it's going to be a mix of S3 and S3 Ultra based on what you already have at your institution. And you won't get a specific kit for the procedure, but you really need to document the exact serial number. But this is what we do on a regular basis. But this will be provided within the CRF. Okay, so we have a couple of minutes for discussion. It was quite dense, so I'm sure you have lots of comments about that. Yes, Sabine?
Hi, I have 2 questions. One concerning coronary artery disease. Is it allowed to do concomitant bypass surgery or stenting prior to TAVI? And in which time frame, before or during TAVI? And is it allowed to use a cerebral protection device?
For the coronary arterial disease, if you have a patient that requires some treatment, what you can do is you have two possibilities. You still have a 28 days window to treat the patient from randomization, assuming that from between consent and eligibility screening, you have 2 days. So you still have 28 days remaining. So you have the possibility of, if it's an interventional arm, of doing PCI before. So you have 28 days. So you can do it whenever you want before or during the procedure. If it's a surgical patient, the recommendation, it makes sense, is to perform concomitant cabbage and SAVR.
Yes, but you mentioned drug-eluting stents must be more than 3 months before.
It's just, if you have a drug-eluting stent, it's for the surgical arm. If the patient is undergoing TAVI, aspirin and clopidogrel is a standard of care, so it's not an issue. If the patient has to undergo surgery plus cabbage and add a past history of PCI, it's better to wait for the withdrawal window, 1 to 3 months, and then consent the patient and move forward. Exactly. And then for cerebral protection devices, this is a really tough question because we're going to artificially favor TAVI because spontaneously we all have the feeling, and based on the randomized trial that we have in our databases, there is a higher risk of stroke, or even if sometimes it's not statistically significant, a higher number of stroke, absolute risk of stroke post-surgery. So if we use cerebral protection devices, we're going to increase that delta. So it's up to you, I would say, but this is something we can all discuss together. There is no consensus within the steering committee. I would say maybe we should avoid the use of cerebral protection devices, just to make sure that for this particular group of patients, we don't integrate something that is going to generate a difference. Stroke is part of the is the component of the primary endpoint, so it should be assessed and in the same way in both arms. So I would say no cerebral protection device. It's going to be only 5 to 10 patients per center. We said not more than 15% of the patients can be included in a single center. So 60 patients maximum. I don't expect a center to enroll 60 patients, but even if you treat 30 patients, you will have theoretically 15 patients in the TAVI arm. So for those 15 patients, it may be wise not to use a cerebral protection device and just to avoid an artificial bias. But this is my feeling. Even if I had the idea of the trial, there is a steering committee and it's still debated in the steering committee. But so at the end, it remains up to you, to the center, to use or not the cerebral protection. But the idea is maybe we should try to avoid this.
My feeling would be it just can show what you can do with TAVI, what you can achieve with TAVI. So
exactly. Yeah. It makes sense, but yeah. So your comment is saying that we need to compare standard of care surgery to a standard of care TAVI. And in Europe, it starts to be more and more cerebral protection. But it's not available in all the centers. It's not used on a daily basis in all the centers. So in Germany, it may be more frequent, but in the other countries, it's not so obvious. So just maybe for the sake of the trial, you could try to avoid it. But if you feel that for your patient, you need to use a cerebral protection device, use it, because it's safety of the patient first, and we need to treat the patients the best way we think is for this patient. If you think that you need to use a CPE, go for it. It's not going to be a huge number of patients, I anticipate, having a cerebral protection device.
I was wondering, with regard also to the coronaries, I would agree with the syntax score high, but why left main, especially now in view of the long-term syntax data? An easy left main revascularized 30 days prior to randomization shouldn't be an exclusion criteria.
Yeah, so you are totally right, and this is a very pertinent comment. And it's first to echo what has been proposed in the previous trials, and second, we are going to integrate different sequences. The patients are going to be treated either with TAVI first and then PCI, PCI first then TAVI, TAVI at the same time. We don't know exactly. It still remains a balloon expandable valve. If you have, for example, the patients with an ostial left main, a low coronary takeoff, you treat the left main, then you put the TAVI valve, then you crush the stent and so on. We want to avoid all these, even rare, if rare, all these potential for complications for our patients. So that's why if we have a left main, it's not a PCI, it's not a coronary trial. It's a valve trial, it's a woman trial. So let's focus on valve and woman. If we put patients with, even if it's minimal, a higher risk of coronary complications, we're going to artificially put some more events in one arm. It's going to be in the TAVI arm. So that's why we said that. It's really easy to treat by surgery. It's easy to treat by PCI. But when do you do that? You put the valve before, you do the PCI after, you put the stent before, you do the valve after, then you have a risk of complication. It's not maybe the right thing to do in a randomized trial. That's why we excluded these patients.
Hi. I would like to really echo your opinion on cerebral protection, because I think it would be really good to have, the best possible outcome as of today from this technology as compared to best possible outcome with a different technique. So I think that would be, at least for us, it is something that we would like to achieve for the best of our patients, number one. Number two is, I could not really understand why you have this complicated randomization process. Why do we have to send the data to a steering committee? Because we could make crosses like yes and no, and we usually are able to make the count. If there is a contraindication, we don't do it. So why do we have to send it to the steering committee?
So so two comments. So the first one for the cerebral protection device, and I'm going to provide the same answer. If you feel that this is the best therapy for the patient, use it. At the end of the day, we don't expect within the steering committee to get a big proportion of patients with a brain protection during TAVI. Then for the screening process, this is a randomized trial. It's not a registry. We have to make sure that the patient, we include a quite homogeneous group of patients. If you're going to see the slides this afternoon, you are the key factor for determining if the patient is eligible or not, because within the screening slides, we don't ask you to tick boxes about the inclusion or exclusion criteria. We acknowledge that you did a thorough assessment of the patient and you made sure that the patient was a good candidate for the trial. What we want to make sure is that we exclude patients with extremely high septal hypertrophy, with non-suitable aortic anatomy for a safe transcatheter valve. And we want to make sure that the peripheral access are perfect. We want to make sure that everything is suitable for a transcatheter procedure. But it integrates something. It generates the fact that the surgical patients need to get a CT scan, because you send the patient and then afterwards you randomize the patient between TAVI and surgery. It's just to make sure that every patient gets the same screening process. We see all the patients because as PIs, co-PIs with Hélène and members of the steering committee, we are at the end of the day responsible of the quality of the data and the patients that are included within the trial. So it's a kind of collaboration. It's not a big effort, you're going to see that. I used to do that for all the randomized trials that I was part of. I used to do that. So at the start it takes 20 minutes and then it takes 5 minutes once you see what you have to include within the slides. You send the slides for us to review. It's going to take 10-15 minutes, get an answer, and then you get your feedback. But just to make sure that everybody is aware that these are not regular patients. These are patients dedicated to a specific purpose, a specific trial, and they have to follow that specific path.
if I may, I have two small questions. Yeah. One is length of stay. I mean, I do understand this, but you know also that there are different healthcare systems. So Germany, for example, with the DRG, so if they discharge patient early, they get punished. In other countries, it's different. So it may be a mixture, and maybe we have to be careful with this parameter to look closer to that.
Yeah, it's not part of the primary endpoint. This is a single efficiency endpoint that we're going to assess in the future. So you are totally right. We will at the end, when if you have ideas about publications and things like that, we will at the end discuss about the opportunity of exploring more length of stay or so on. It's not going to be a part of the primary endpoint or a big endpoint, but because we all know that the local policies differ.
And final question is, yeah, sure. BNP and anti-pro-BNP. So you have BNP, you're also allowed for anti-pro-BNP?
So this is something that we didn't, so BNP or anti-pro-BNP, it's BNP that is mentioned. If anti-pro-BNP is only available at your institution, we're going to have a set of amendments to the protocol. So maybe this is something that we can add just to make sure that we also connect these patients with the anti-pro-BNP assessment.
There are not a limitation on the basis of the STS score. We can enroll patients with low risk, intermediate, high.
So this is a paramount question. You can enroll all types of patients. This is an all-comer female study. But at the end of the day, we expect, as it is contemporary practice, and the patient has to be suitable for surgery, that we are going to enroll more intermediate to low-risk patients. But you can enroll all types of patients as far as the patient is still eligible for surgery, for a safe surgery.
What do you expect for older female, I would say more than 80-year-olds? Do you think that centers are going to randomize those patients? And do you think that the patients and their families will accept to participate to this study?
So this is once again a key question, and I'm really glad that both of you came up with that. The profile of the patient that we're going to get. We are in a contemporary era. We all treat on a regular basis patients with TAVI above 80 years old or even 75 years old in some centers. So that's why we expect to enroll maybe more potential candidates, surgical candidates, and then they get the opportunity to get a TAVI procedure within the randomized trial. And for sure, in some centers, it's going to be an obstacle. If you have a 80 years old or plus patient that is identified as a TAVI candidate, it's going to be difficult to bring the lady back to surgery. So that's why it's maybe within the firstly identified as surgical candidates that, depending on the country in which you work, you may find these patients. It's not a big number of patients, so we have to make the effort maybe to screen also the surgical candidates, the regular ones, to see if there is a benefit in this female population to get a TAVI procedure. So how do you foresee that, Hélène, for example, at your institution?
No, I totally agree that an 80-year-old female, I think the patient will go to TAVI because this is the current practice. And I think we'll focus on the ladies who are supposed to have surgery because they are either 70, 75, up to 80. For example, in France, below 80, they still go, the patient are sent to surgery. But we have also to exclude the bicuspid valves. So we'll have lower risk female, but without bicuspid valve. So probably around 70, 75, something like that, or close to 80. But for sure, it will be presented as you should go to surgery, but you can participate to a trial and you will be randomized and maybe you will get TAVI or surgery. I think this will be the population which will be treated.
And what about the German sites? Because it may be an issue in Germany. Do you have any, you'd like to comment on that?
So I think in Germany, as we also run the DEDICATE trial, so that, as you know, the risk, the STS score decreased from intermediate now to low and now to no STS score. So I think this will be also the female population which we would screen for DEDICATE, we would screen for Rheia.
Any additional comment?
I have two comments. The first one is about the statistical analysis. I saw that, as usual, you fix the p-value at 0.5. But we have a 6% non-inferiority. I understand, right? The cutoff for non-inferiority was 6%. So how do you establish 6% if we accept a p over 0.5? So 5% of chances.
Yeah. I don't know if I got it right. So from partner 3, you have the 6% non-inferiority margin, and we calculated patient numbers based on this non-inferiority margin of 6%, together with the partner data, which kind of showed that female would have a 18 versus 8% risk. So we arrived at around 130 for non-inferiority, but we felt that non-inferiority is not the way to go in this particular trial, because we feel that the TAVI may win because of the partner 3 data showing 18 versus 8%. So we, in the end, went for 400 patients. I mean, you can always discuss whether it should be 450 or 350 or something, but 400 is a fair number. And adding the 40 patients that you need as a buffer to have really 400 with a primary endpoint after 1 year is the way that we went for the trial.
And the other question is about the number of patients to be enrolled, because you established the power analysis on the partner 3 results. But if you will reach very lower results, you will have an underpowered trial. So how would you fix this possible event?
You foresee that we have less events than in partner 3?
I think that it's possible that surgery will reach lower events than what published in the partner 3 trial. So I don't, it's not my experience, but it's not the experience of most of surgeons to have 2 patients on 10 that dies at 1 year after surgery, especially in low risk. So I imagine that we will have 5%, 3%, 4%, maybe 10% at 1 year. How would you fix this?
I mean, I think in partner 3 we went for low risk patients. What I see to be enrolled in this trial are low to intermediate risk patients, so maybe on the higher side. On the other hand, we based our sample size not on the 18 versus 8, but 15 versus 6, or 15 versus, so slightly lower than the actual rates that were observed in partner. So we took a conservative approach to determining the sample size. We don't have a formal interim analysis, but what we will do, and this is the purpose of the 6 months telephone visit, we will assess the potential outcomes after 6 months and to extrapolate whether we would be able to reach the endpoint and decide upon this findings whether we need to amend the trial. We don't foresee that we need to amend the trial, but we would know early if so. Initially, we thought that an interim analysis based on the primary endpoint after 1 year would make sense. But if you see that patients are observed and followed for 1 year, and then you do the interim analysis, the rest of the patient has been recruited already. So to make the interim analysis based on 1 year data is just not feasible because the trial is over or the recruitment is over at that point.
That's not a statistical comment. About the screening process for all the interventional cardiologists here, there will be the patients that we have to include in the study that we don't see normally because they get referred to surgeons from other centers, having done coronary angiogram at other centers, and we don't see them, or maybe sometimes we just do a coronary angiogram pre-op. Is that correct? Yes. So we have to get into surgical clinics or get the surgeons really on board.
That's exactly... I think that's the point. If we think about the difficulties in enrolling patients, and to echo the comments from Hervé Le Breton, maybe we will have to approach the surgical department. So it means that you need to discuss within your heart team about the distribution of the roles, and the surgeons have to be on board because it's about the overall care of the patient. It's not a TAVI only trial. So we need to approach the surgeons to make sure that they identify the appropriate patients and that we get the appropriate testing, screening of the patients before a randomization. So it's true that mostly what I foresee is to see more surgical type patients than interventional ones. In our institution, we see also surgical candidates, so it's not going to make a big difference. But from different part of the Europe, we have different policies.
Because the straightforward surgical cases don't get discussed in heart team, they just go straight to surgery. In my center.
Yeah. On a regular basis, a surgical candidate is operated on, but this is for a randomized trial. So you need to identify the surgeon who is going to partner with you, or the surgeons. You may have a couple of surgeons working with you, and just engage them in the screening process, in the discussion, and so on. And it's only about the numbers. We expect 10 to 15 patients per center. Half of them are going to be randomized to surgery, so it's 5 to 7 patients. It's not a big number. Okay? If you go and discuss it that way, I don't expect so many difficulties.
I think it will depend on the centers, because the opposite in our center, it's exactly the opposite. All the candidates come to the cardiology department. So I don't know the distribution among the investigators, but...
So maybe a very simple question. We have the opportunity to have many surgeons. Do you think that you're going to refer candidates to the trial based on the ones that you get for operation? Raise your hand, from the surgeons only.
They are here today, so...
Yeah, we have surgeons. So they are here, so you already have your answer, because we already have surgeons being part of the trial, and as far as you discuss and you make sure that everybody understands the benefit and the potential for our patients, it shouldn't be a problem.
Yes, do we have surgeons that do both TAVI and surgery? So it's not a department versus department trial, but a technique versus other technique trial.
Yeah, well, we have a common heart team. So in our institution, we started 1st of April this year, actually, that all patients have to be seen by the heart team. May they be straightforward surgical patients, they stay surgeon. The heart team decision will be surgery, but all are to be presented to the heart team. So we have no exemptions anymore at our institution. So everybody is seen by the heart team. So I expect no problems there.
Cool. Just another technical question. Is rehospitalization for wound lesions, for example, considered an adverse event and is included in a primary endpoint?
It depends. If you consider that wound infection as if it comes from the groin, you consider it as a vascular complication. It's going to be adjudicated as an event within the trial. So we have a dedicated clinical event committee that is going to adjudicate all the events. So what you have to do is to collect. If it's not a part of the definition, it's not going to be included. And once again, this is not part of the primary endpoint. It's valve-related, procedure-related, or a worsening of heart failure. So if it's procedure-related, you have a wound infection 2 weeks after the surgery, we will have to adjudicate it as a complication. Rehospitalization, procedure-related. So just to be fair for both arms.
You schedule the main point at 1 year as usual, but what about the long-term follow-up?
So it's a very important comment, Hervé. Long-term, it's going to be mainly a lower risk population. So ideally we will need a longer-term follow-up. We have the fundings for 1 year to run everything in the best way possible for 1 year, and then we will discuss. I guess it's going to be after, once again, an investigator-initiated effort. We will have to follow up these patients, at least clinically or by echo, on a yearly basis to see what is the duration of the valve. But we're going to get some insights with the partner-free and the low-risk trials before that. So ideally, we should continue to follow up these patients, but we don't have the fundings for that. So this is something that we keep in mind, and we can discuss that afterwards. If there is an opportunity to continue the follow-up, we will do.
Just a curiosity, Didier.
Yeah.
So you previously said that you're going to try to find out if there is some differences in this kind of patients in using the S3 or the ST Ultra. but there is no planned proportion of valve types. Okay, so it will be an incidental finding. So.
Yeah, it's not predetermined because it's really difficult to anticipate because the approval process is going to differ. And for example, it's not available in some countries. It's going to be available during the timing of the trial. So we don't know exactly what is going to be the proportion of S3 and S3 Ultra. But you're right, it could be an incidental finding, but we'll see. Okay, anything else you would like to discuss? Okay. So I guess we have a couple of cases before break from Mainz. You are the guy. So you can.
Does it work like this?
Yeah, you just.
Okay. So, hello. Thank you for the invitation. I'm Alexander Tam from the University of Mainz, and we're happy to share our early experience with the Sep2019 Ultra valve, which we could use as the first center in Germany with the old commander system we all know from the Sep2019 and with the e-sheath. And just to update everyone on the Sep2019 Ultra system, it's the Sep2019, of course, it's the same frame design, it's the same bovine pericardial tissue we know, but on top, and what's new, is the new much taller outer frame of a new textured PT material. So you can see that here. And here we can see the exact differences. So it's just one diamond, the outer skirt moved one diamond up, and it's not this flat fabric anymore, it's a textured fabric. Looks like a little bit, if you see it in live, it looks a bit like somebody stole the wristband of Ivan Lendl from the 80s, so it's really like a puffy skirt. And what we can achieve with that is that we have much more contact area to the native anatomy. So it's 50% more. And why does Edwards even did this? They looked at the Partner 2A trial, and they could see that in the bigger prosthesis sizes, like 29, also 26, we see very good results concerning the perivalvular leakage with like non-trace and mild overall, and just a really, really small proportion of moderate AR. But in the lower prosthesis sizes, we could see a much more proportion of moderate and also mild AR, and that led to the design of the Sep2019 Ultra, which, of course, for that case, now we have in the 2023 and 26, and the 29 is still the old Sep2019, but we won't think that there will be any issues with the PVL. And on the other hand, well, it goes like this. It's the same frame than before, with a low frame that allows us for good coronary access. And so we are treating more younger patients, patients with low risk, and we all know that we want to have good coronary access. So that, of course, stayed the same. But this is a crucial point also for us in Mainz, that we are able to treat a lot of young patients, low risk patients by now after the Partner 3 data. And this is a key point for us to use the Sapien valve in these patients with coronary artery disease, so that we have a good outcome for these patients in the upcoming years. So this is something you already know. So the Sep2019 Ultra was designed as an already mounted device, and with a new delivery system, new sheath. And because of some technical issues, the company moved back, and this is exactly the thing we know before, like the Edwards Commander delivery system, really well known, and the e-sheath introducer. Right now there's a little bit bigger loader to load the delivery system into the e-sheath. Maybe they will come up with betterment after that, because it's a little bit too big right now, but everything else is quite the same. And so we're literally dropping our trousers here, and I will show you all our 8 cases we have just briefly, but all our 8 cases we have in our centers, the experience from starting 2 weeks ago till yesterday. So first one will be an 80-year-old female patient with severe AS. You can see it here. She has mild coronary artery disease, atrial fibrillation, and a history of stroke with no residuals. Of course, severe aortic stenosis was confirmed. And you can see the CT scan. So our first ultra patient was quite nice. Tricuspid, not so hard calcified aortic valve, a root and aortic arch axis that is favorable, and also the peripherals were very favorable for TAVR. And just to show you how it works with the Ultra in the commando delivery system, as you would expect, it's exactly the same like in the Sapien 3, and it also works very easy. So it's no pushing against something or no worsening of the alignment or of the delivery. Crossing the arch and crossing the valve is also easy, as you would know it before from the Sapien 3. And also retraction of the flex catheter of the pusher is easy as it was before. So there are basically no differences in the delivery of the valve, and also, as I would say, no difference in implantation. That some centers that use the mainly designed for Ultra system that mentioned some issues with the balloon before, so we have like the old balloon system now, and the implantation is quite like you would know it from the Sapien 3. So Sapien Ultra, and this is like exactly the final result, 30 seconds or 1 minute after the implantation, so we had no PVL at all in our first case, also shown on the echo on table. In second case, was a little bit harder, was a little bit more calcification. 40-year-old, again, female patient with very tortuous anatomy in the peripherals and also in the aortic arch. But you can see as well that there was a good delivery of the Sapien 3 Ultra here. So no problems at all. And again, a little bit deeper implantation, but again, no PVL at all. And so I want to go a little bit fast forward. So again, a female patient, 79-year-old, very much calcification on the RC. And again, no PVL at all. So this is something we wouldn't have expected from the Ultra before, that it was so good, but first 3 cases. No PVL, and case 4 was a 76-year-old male with not so much calcified aortic valve, and somehow the video won't run.
Can you manually start?
Ah, now I do. And this was the first one we saw, like trace to mild PVL, but this is the echo from the next day on the regular ward. So again, no PVL at all. And 86-year-old male patient. I'm going fast forward, but you get the point. So we really, and this is unfortunately a patient that wouldn't be in the study, but 70-year-old female patient with typically bicuspid valve, type 1, L and non-coronary, LCC non-coronary RAFA, and very horizontal aorta, and again, no PVL, very good case, which a patient that wouldn't be in the study, but maybe we could have an amendment because we can treat them so good. 79-year-old male patient. And the last case, from those who know these pictures, you see the valve is totally fine. 90-year-old female patient, severe AS with no PVL at all, but you might recognize the pictal catheter here. There was a wire injury of the myocardial, and we had a pericardial infusion that has to be drained. So, but anyhow, to conclude this, in our early experience with 8 cases now, starting 2 weeks ago, loading, delivery, and valve crossing and also the implantation was as easy with the Sapien 3 valve. We treated different anatomies with the Sapien 3 Ultra and showed the valve, the prosthesis showed equally excellent results. And this is nothing I made up, so I didn't exclude any patient. It was really all the 8 patients. All patients we treated, mine so far, had 0 PVL. So this will be, or I hope this will be, a really good valve and treatment of all the patients that we will have also in the study. So thank you from Mainz. Any questions?
How many of these patients might be candidates for Rheia trial?
For me, we had 5 female patients here, so the 90-year-old maybe not. Maybe we, so in our centers, and I talked to our surgeon that is in our heart team, and I think we will include young, low-risk female patients mostly into the study, so like in the age of 65 to 75. This is something that we will go for, and so we, but maybe also this 76-year-old female patient would have been in the study as well. But our heart surgeon, as we told before, he will bring us the patients, or he will maybe screen for the patients that will go directly to his department and come to us and say, this would be a patient I would include in the trial as well. So.
Yeah, I have very nice cases, especially the bicuspid and the horizontal aorta. I was wondering, not very severely calcified, and you didn't show any LVOT calc. Where in your vast experience is the cutoff now for calcification? This was also one of the surgical comments with regard of the partner 3 selection criteria.
Yeah, calcification of the valve I wouldn't exclude at all, so all these patients do very, very well. If there's severe annular calcification in our department, we would go for a self-expanding valve.
Severe LVOT, actually, so the annulus is not so much the problem, it's a little bit more prohibitive, short axis calcification, and perhaps calcification, massive calcification extending into the LVOT. That's the only risk situation. This was also excluded in partner 3, so I would also exclude this here.
So it once again echoes your comment. That's why we want to see the CT scan before randomization, just to make sure that we select the appropriate candidates and we avoid these 2 risky patients. Yeah. I had a question for those who have experience with the Ultra. We see that there is an extended skirt, so theoretically or potentially there is a higher risk for a higher gradient, so more folding in the anatomy, so lower, less expansion of the stent frame, higher gradients. Do you see any patient prosthesis mismatch more in that S3 Ultra population as compared to what you've done with the S3?
We haven't seen it in these 8 patients, so they were all had like the gradients we would know from Sapien 3, like it's intraprocedural. If you measure it invasively, it's like 0, 0, 1, 2, and they have a mean gradient at departure between, let's say, 8, depending on the size of the valve, between 8 and 13. So this is something we would know before. So nothing there, but we will.
What about pacemaker and pacemaker?
We had no pacemaker in these patients.
So quite reassuring data about the gradient and the pacemaker rates, because these were concerns that people had in mind when this device came out. Maybe we're gonna be extremely efficient for PV leak, but the trade-off will be higher gradients and higher risk of pacemakers. So.
Yeah, might be. What I think is the Sapien 3 was already very forgiving valve, if like the implantation is not totally on point, and we see one patient that was quite low, so it was like not implanted like 1910 or 80-20, so more like 70-30, 60-40, but still there was no PVL. So I think this is a big achievement of the taller skirt, so that if you don't have the ideal implantation, still there will be no PVL, and I think the valve works fine and the gradients won't be an issue.
So I had a comment from David saying that we don't have within the exclusion criteria a cutoff for the coronary height. It's not part of the exclusion criteria, but we will make sure during the screening committee review that we anticipate a very low risk of coronary obstruction for a dedicated patient. If you have a low coronary height but really large sinuses, the risk of obstruction should be minimal. On the other hand, shallow sinuses, low coronary height, or extremely calcified leaflets, these patients may be also excluded. So that's why we want to see at least the screenshots of the CT scan before the procedure.
Yeah, I may probably add to the performance of the Ultra. We have done 50 or 60 so far since January, and hemodynamics were very good. Actually, we did not observe gradients or any obstacles with that. And regarding coronary height, I mean, do you recommend a cutoff?
No, there is no.
Okay, so 6-7 millimeters is fine.
Depends on the overall anatomy of the arteries.
So we have only benefit.
Yeah, absolutely.
Lunch is prepared, so we can have lunch. Maybe 1 hour lunch break only, and we start again 12:30. In 1 hour.
Okay. As you learned from Didier, we will have a legal sponsor for the study, which will not be Edwards, which will hand, so the responsibility for the legal representative has been handed over to SSS. As not all of you may know us, or maybe only a very, very few of you know us, I will just give you a short introduction, who we are, where we are, and to inform us about our work, what we will do, and how we will collaborate during the study. Short agenda for the study, for this presentation. Can we skip? So for the sponsor, we are SSS, it's a CRO. We are based in Germering. Germering is it's a few kilometers west from Munich. So if you remember Munich, that's okay. The name SSS is derived from the 3 founders. They all started with the S. That's the reason where the name comes from. We are now 26 years to be exactly on the market. We provide full service CROs, which means monitoring, ethics approval, authority, regulatory approval, monitoring, report writing, data management, everything is needed for the pharmaceutical industry. We have, our main office is in Germering, but we have also smaller offices in Poland and in Romania. We have, at the moment, around 50 employees, but for larger studies, we have partners, sub-CROs, also sometimes freelance CRAs, and local CROs or data management with whom we collaborate for different studies. And for this study, we have lots of studies performed in cardiovascular research and also in medical devices. The countries which are involved in the Rheia study, the green ones are handled by local CROs, it's Scandinavia, Italy, and France. And the countries in blue are handled by internal CRAs, which will all be in contact with you or contact you in the next days. Ireland may be added into the study. At the moment, Scandinavia, we have only Sweden, but maybe the site selection has not finalized, so maybe we Denmark will be included, or Norway. We will see. Our local CROs are Hippocrates in Genoa. That's a CRO with which we are collaborating since many, many years. Also ClinSearch, we have done several studies before. This is a CRO for France. IRV for Scandinavia. And data management will be Exact in Cologne. So I will show you the people, I will present the responsible people afterwards. So the project team at SSS, it's our CEO, Michael Sigmund. He's one of the 3S. He will sign the contracts with the sites, or if he's not here, also Lars Behrendt can sign. He's at this meeting too. I will be to the project coordination, so overview of the ethics committee approval submissions, regulatory submissions, coordinate the CRAs and informs them about sites, and so everything what's the daily business. We have 2 lead CRAs, Astrid Schwarz, she's here too. Sigrid is on vacation, she's not here today. And we have a quality management, Angelika Scherer-Beckenbauer. She may perform, maybe she will perform an on-site audit or accompany a CRA for audit purposes. So you may get to know her too. So for Austria we have 2 sites at the moment, Wien and Innsbruck. The CRA for Austria will be Chicha. She is at the meeting here. No. France, we have ClinSearch, Guillaume. France, I think, will be the biggest countries regarding the sites and maybe also the patient recruitment. At the moment, we have 6 sites in France confirmed, but no, 8. 8 already, okay. So I think this will be very, very big sites. In Germany, we have 5 sites confirmed. Maybe a 6th site will join. The CRA will be Peter, who is also attending this meeting. Italy, we have 4 sites. CRA will be Simone, also here. Netherlands will be handled by Olga. We have 1 site, but other sites may be added to the study. Scandinavia confirmed until now is only Lund in Sweden. Rheia will be the monitor, but as you see, there are several other sites which may be added to the study. Switzerland will also be handled by Chicha. 4 sites at the moment confirmed. United Kingdom will be handled by Olga. Also, maybe some sites in Ireland will participate too, but that's not finalized yet. Data management will be done by Cologne. Rheia, he'll be our data manager. He will be responsible for everything. For all the countries, he will have most of the work. Just a overview about our connection with the sites. We will have a study initiation visit. This visit will be done on-site, not remote. It will be done as soon as all legal things have been done. This means after the health authorities approval has been given, after ethics approval has been given, and after the signed contract is available. Then we will have 3 on-site monitoring visits. On average, of course, sites which will enroll many, many patients, up to 60, will be visited more often, whereas sites who have only 3, 4, 5 patients maybe enrolled will not be visited so often. But on average, 3 monitoring visits per site. And on 1 close-out visit on site. And in between, we have 10 remote monitoring appointments. This means the CRA will look into the data, will call the study site, will make an appointment with the study site for a phone call, will discuss open queries or data which seem to be inconsistent, missing data entries, and so on. Or maybe if a visit, maybe the 6 months visit date has not been entered for a long time, the CRA will call or also call the site. Why does the patient, was he not called the patient? What's happened to this patient? So these are the things which are part of the remote monitoring appointments. So the status quo, we have the final protocol as of 16 September. This protocol has already been submitted to ethics committee. At the moment, we have the patient information and consent form under construction. I'll try to finish it next week, and then we will have it translated into every language. We are working on the investigator contract. The template had changed a little bit. We will need to update it for medical devices and for SSS as a sponsor. Also, the manuals will need to be written, like the screening manual, the screening procedure, which the DA already will provide in detail. What about the SAE reporting procedure, the echocardiography? There will be needed, a manual will be needed. We will prepare the investigator side file with different working forms for you. And the CRF will also be worked upon, I think next week. We will have several calls, and this CRF will be set up until. We need this CRF until, let's say, at least until end of November, beginning of December, when the first patients will be included and hopefully be randomized, because the randomization will be done via the eCRF. As the status quo, the patient, the site recruitment is a little bit not so current any longer. So Didier also showed this slide, and as previously noted, many other sites will join. We plan 35 to 40 sites, and 31 sites confirm participation, and other sites will be added. But in the investigator file, we will also include a site list so you know which colleagues of you are participating. For the submission status, France has submitted yesterday, and submission to Innsbruck also has been done yesterday. For Austria, we are still waiting for the answer from the AGES, whether we will need approval from the AGES or not. Then we will continue after the consent form has been finished with Germany and UK, because there also will be a lot of sites. Italy also will be, I think, a very big country with many patients, so we also should start Italy within the next few weeks, 2 weeks maybe. And also Switzerland is a country which can be submitted in the next time. And then we have Sweden, Netherlands, as this also should not be so big problem. Also the Netherlands, the Dutch side wants to submit in the next few days, or after all these forms had been, for submission had been finalized. So the current planned time schedule is to have the first patient enrolled still this year. This may be in Austria or France maybe, we will see. We plan to have all sites initiated until the first quarter of 2020. Then we have 1 year for enrollment. All patients should be in the study until February 2021. Since the patients will be observed for 1 year, okay, we have a time window of 1 month, so it may be March 2022. Then we have 1 to 2 months for database lock, and the final report will be written in summer 2022. So that's the current plan, and we are doing everything to adhere to this and go on with the submission in the next weeks, and try to have submitted all the countries still this year. So, first questions for our daily work.
in Germany, especially for the local authorities, there is no deadline for response. So this may have to be addressed. For AMG or MPG, they have a 3 weeks response time, but for the others, 23B like this one, it can take some time.
Yeah, we also have to, in Germany, we have to clarify with the authority whether we will need approval from the BFS. Because of this CT assessment, a CT is needed for the study, so we will need to clarify. But submission, I think submission will be done anyhow within the next few weeks. And then, of course, we hope to have approval by, let's say, maybe November, December. And then we can start also in Germany.
And for example, in Italy, do you expect it to be difficult to get acceptance from the ethics committee?
It will take some time, but we don't expect any real difficulties.
It depends on the ethics committee and in the cities, and for competent authority, I don't think so. Yeah. So just need the notification, so it should be quite easy. Depends on the ethics committee of the cities anyway. Yeah.
As the latest studies we did in Italy, it was very, very fast. So at least the big hospitals are quite fast at the moment, yeah.
So any questions, maybe from the research coordinators? Any comment? Okay. So we're going to move forward. Thank you, Christine. Thank you. Tiens, c'est pour toi. Hein?
So now it's a very important part. Didier will present the screening, what we have to do after having performed the screening and having obtained the informed consent. It has to be sent for confirmation, so you will explain that?
Yeah. So we're going to go through the slides, the slide deck that you need to provide to the eligibility comment for inclusion within the trial. Just before we go through the slides, I had a couple of comments before lunch about coronary artery disease, about the ability to treat the patient by PCI and then undergo surgery. You can do that. If you find a patient with a concomitant coronary disease and aortic stenosis, and you think that this could be a kind of half-breed patient, you can do the PCI, but you must not consent the patient at that time. You do the PCI, you wait 1 to 3 months according to the type of DES or BMS that you have implanted, and then you bring back the patient, you get the consent, and this becomes either a AVR or a TAVI patient. So you can do so. If you feel comfortable doing this, you can. This is a possibility. Or, on the other hand, you can go for a concomitant procedure, PCI, TAVI, CABG, and AVR. Okay, so I also had a comment about in some centers, CT scan as acquisition is part of the standard practice, so it's not going to be an issue. In other countries, it's not standard of care, particularly for the surgical arm patients. So what you at that time for the screening, we don't need you to upload the full set of images for the patient, DICOM images. There is not yet a CT core lab. We have an echo core lab. And if you, normally you should get the echo per protocol, according to the protocol, once you have consented the patient. So if you can do so, it's preferred. If the patient is not consented, you cannot send any image to the clinical, to the steering committee. So you need to consent the patient first, and you need to get a proper CT scan before that. So you will get a dedicated email address. That email will gather and collect all the slides from the patients, from the potential candidates. It will be distributed to the steering committee members and the PIs, And then we will review the slides within 2 days and provide a feedback within 2 days. And at that time, you will know if the patient is eligible or not, and if you can proceed with the randomization. So it's a very simple way. You send the slides to that address, and if you have any kind of question, you have dedicated emails for that. So we're going to go faster. So this is the type of slides that will be required for the submission. So the first slide, you need to enter the matrix of the patient, the age, gender, to make sure that it's a female, because it sounds logic, but sometimes we can forget that this is a gender-based trial, and we can propose sometimes male. We have to make sure that there is that it's clearly a woman that has been submitted. So the patient needs to be symptomatic. Yeah. So the NYHA class, and then the matrix, just to be able to confirm that the aortic stenosis is severe and so on. So if you have any item that you want to include in that box just about the past history of the patient, you have that field that you can fill in just to provide clinical information to the steering committee members. Then we move to the echo assessment. The echo window is 90 days, 3 months. So if you have a past echo that provides these very simple informations, you can use that. And then once the patient has been randomized before the procedure, you need to repeat the echo. You will need to repeat the echo according to the protocol. So just to make sure that we get the proper images. Ideally, the initial echo should be per protocol, but if you don't have it yet and you want to consent the patient and send it, you can do so, but you will need to repeat the echo according to the protocol before the procedure. So these are very simple metrics, the gradient, the area, the annular diameter that has been estimated by the subannular plane, the LVEF, the severity of AR, MR. Make sure that you are within the 90 days window for that echo. And if you are out of window, you need to anticipate the date to which the echo will be repeated. So just to keep in mind that we have to remain in that window. And for those low flow, low gradient AS or asymptomatic patients, we want to record the ejection fraction, the movement, the difference in the mean gradient, and the amount of the micrograms, the amount of the butamine that has been used for the patient. Also required, if you can insert loops of the jet velocity, it's preferred, but steel frame is okay. And it's the same for the long axis image of the left ventricle and the aortic annulus or the aortic valve. You can do that. Loops are preferred, but steel frames are also accepted.
So I got this right. If the echo was done within 90 days, it doesn't need to be repeated, only if it was without the 90 days.
It doesn't need to be repeated if it has been acquired according to the protocol. If it's not according to the protocol, you will need to repeat it anyway. So it means that if it's feasible in your institution, you could say, okay, every AS patient is going to be screened this way with these views and so on, just to match the protocol, but it's not mandatory. Okay, so just as we said this morning, it's up to you. It's your responsibility to make sure that the patient fulfills all the inclusion criteria and the exclusion criteria, because we are not going to review all the blood testings and so on. So if there is something that is questionable, you can put it within these boxes, and then the steering committee members and the PIs will determine if the patient is suitable or not. If you have any doubt, either you directly contact us or you put this in the slides, and we will provide an answer. So the risk scores, this makes sense, and we're going to collect all 3 risk scores, even though we mainly use the Euroscore 2 and the STS score in contemporary practice. We also want to record the logistic Euroscore just to get a better understanding of the risk profile of the patients. So coronary evaluation, you can put still frames. If you have time to put loops, it's okay. But at least one significant picture of the right coronary artery and two from the left side with the LED and the left circumflex. If there are stenosis, we want you to provide your estimation of the percentage of stenosis in this field and calculate the syntax score and make sure that the coronary angiogram is within 90 days. So it's a quite large window. If you have somebody that has been screened in another hospital, you can still provide the pictures from that coronary angiogram. But if it is out of window, you will need to repeat it.
Is it mandatory to do the cath, or because sometimes we we only do the CT scan, so we always do the CT scan for all our type of patients, and then we decide if we do the angio, because sometimes we just can exclude coronary artery disease and we don't need that.
So I have to say that what is recommended is a coronary angiogram, but we need to. We have to be quite consistent, and maybe for these patients that are being included in the trial, we need a coronary angiogram, just to make sure that everybody is assessed the same way. But if you already have a clue of that, of the absence of coronary disease on the CT scan, maybe you can do a very quick, really fast quick shots on the coronary arteries, avoiding to put a too aggressive load, contrast load to the patient. But coronary angiogram is required. Okay, and then the syntax score. So for the CT analysis, it's the same. The window is doubled, so it's 180 days, 6 months. So you have 6 months. If the CT scan has been done in another hospital, you can use it. Ideally, what we recommend is to get a non-contrast CT and a CT with a contrast. Non-contrast to be able to measure the calcium score if needed. If it's not part of your routine practice and you have a low flow, low gradient patient, you don't know if the aortic stenosis is significant or not, a non-contrast CT is recommended. So for example, in our institution, it's systematic, non-contrast and contrast. So it's really about adapting the protocol that you use. It's not shouldn't be a big deal. So we want to see the dimensions of the aortic annulus. If you have a steel frame with the metrics, the measurements of the annulus, with the perimeter, the area, everything, min and max, all the softwares provide that. Be sure that we can clearly identify all these metrics in that window. It's the same for the LVOT and the sinus of Valsalva. And then you report everything here, just to make sure that it correlates, and we are talking about the same patients. And there aren't any exclusion criteria concerning coronary height or dimensions of the sinus of Valsalva, but we want to make sure that the patient is not at extreme risk of coronary obstruction. So we ask you to integrate the dimensions of the sinus of Valsalva, the STJ, the coronary height both from the left and the right side, but also the amount of LVOT calcification. And so it should be, maybe if you have a extremely calcified LVOT, you should make sure that we see the outflow tract clearly to appreciate the amount of calcification in that window. And then the femoral axes, we only ask for a short axis of the minimal diameter of the common or the common femoral artery or the external iliac at the minimal point, just to make sure that this is a suitable transfemoral candidate. And then we ask you to report the minimal and the maximum diameter achieved both by the right and left common femoral arteries. And at last, a 3D rendering, a 3D reconstruction of the iliacs, the terminal abdominal aorta. If you have everything from the aortic arch and then the abdominal aorta in the iliacs, it's better. If you want to focus on the distal abdominal aorta and then the iliacs and the common femoral artery, it's also accepted. Better is to see the overall arch and everything, if you can do so. But focusing on the distal part is also fine. And then at last, we ask for your decision about the planned valve type, the size, S3 Ultra, the size, the access site, and when you plan the procedure, just to make sure that you remain within the window that should be around 28 days for your patient. So it's going to be, if you have an idea or already an idea about the surgery, you can put a word about the planned procedure there also. So that was all. So you see it's quite simple. It's not extremely demanding in terms of items to fill in, but these are very specific items, just to make sure that this is a female, symptomatic, that fulfills the inclusion criteria with no exclusion criteria at all, and a suitable anatomy if the patient is randomized to a transfemoral procedure. So it may sound a lot of work at the start, but once you get used to that, it's very fast to achieve. Okay, do you have any comments, any question?
No, I just like to make a comment because at least in our center, we're not used to treating surgical candidates with TAVI. They go, as I said before, they go to surgeon. So that would be the point where we will get the patients from, I think, from surgical clinics. So they usually get the angiogram already done, echoes done, the carotids are done. The only thing that's missing really would be a CT. So at that point, the surgeon will have to, or someone identifies the patient as in a pre-screening process and says, look, this is a possible candidate, let's get a CT, and then we can screen and randomize the patient. Is that correct?
It's exactly the sequence that you will have to apply if the patient is from the surgical arm and CT is not routine, done in routine.
Okay, thank
you.
you.
I would do that. Identify the patient, potential candidate, and bring him back for a CT scan, and then finalize the eligibility. Okay, I think so. If there aren't any additional comments, we can move forward. So it should be very fast. You send your slides to the email address. We review everything, and we provide the feedback. It's too early for Philippe, I guess, so we're gonna. Okay. Yeah, because
it should be
the next one.
Okay, so like announced, my name is Richard Schloman. I'm from Exact Cologne, and we do the data management for this study. The short agenda, I will have a short overview about the EDC system we use, some words about the user roles, and some words about the training and how to receive the access to the system. The best topic, query management. I know in every study is really important to know about the queries and how they are solved. And the last part is the help desk support, just the overview. And I will end with a short view to a demo of a CRF. So it's not for this trial, it's just the demo that you have seen, the system and the functionality. We use ClinCase for the study. It's a very user-friendly system, and it guides you through the activities you have to do. So there will be assessments shown up or disabled, depends on the previous entries. All major browsers are supported, and there's no requirement for Java plugin or something like this. Just JavaScript needs to be enabled if it's due to security reason in a hospital not activated. And yeah, there's a on-page data validation, so there's no need for press save or press confirm or something like this. If you enter the data, it's in the database, and it's directly run through all the validation check on this page. And security time, of course, and I think it's 15 minutes, and you get back to the point where you are after you enter your password again. So quite usual. We have primarily two standard rules. This is the investigator and the study nurse, study coordinator. The single difference is just that the investigator have the signature right, and of course some read-only roles, some CRR roles, data management roles, but read-only access there. We prepare always an interactive e-learning, so you will receive an email with a link to the e-learning system and have to look to some slides, some information about the system, of course, and the study as well. At the end, it's a knowledge testing with some multiple choice question. And if you pass it, then you receive your certificate. With the certificate and an additional account activation form, you send it via fax or email to us, and we activate your account within 1 day. To make it a bit more easy to understand, we receive from, I think from SSS, the list of user accounts or user for the site. You get an email invitation, you start the e-learning, you do your knowledge testing, you send the certificate and the account form to us, and we activate your account. You receive your email with the username and password for the system, and you can start with the data entry. We have in the system two query types for the online checks. Hard checks, usually data checks that the start date is not after the stop date. These checks required data change. You cannot confirm them or close them. You really need to change the data. And the soft checks for requests if the range or the value is out of range, or if there's any other issue there. Of course, there's manual questions from us, from the data managers, or from the CRAs, and you have them in a similar view there. It's always on the items, and I will show you in the demo that you have quick access to the queries. And we will close the online checks as well, the DM checks in our house by ourselves, and the monitors close their monitoring checks. Help desk support, it's done by us, the usual business times, and via email or phone you can reach us, and we will help you there, but normally it's quite easy, and the password policy and so on is easy to remember. Okay, so now I have to switch. So let's see if the technique works. Yes. This is the login page. You see username, password. We often, so I hope, yeah. How I can turn this off? Oh, okay. Oh, the best way. We have the password rules also below there for this trial, or for the usual trial there. And you have the option to reset your password just with this link. I just noticed that you see still the presentation. Now you see the screen. Yeah, here's the forgotten password link. You can just click, enter your username, your email address, and then you receive a one-time password and can reset your password if it's forgotten. Usually it's 3 times that you can try your password, so I always recommend if it's 2 times failed, then please better reset to a new password and not try to the 3rd time or the 4th time, because then your account is locked and we have to reactivate your account. If you sign in, you see kind of a landing page. On this landing page, you have, of course, again, the help desk on the upper part where you can reach us. We provide important study documents to the landing page, so the study protocol, SIA reporting form, or other documents which are important, maybe the PowerPoint slides. Let's see what is reasonable there. Some main contacts, this is configurable, and like I said, it's a demo. If you go into the study, you just open the study books and get an overview about your site, how many subjects are in. You create a new patient, and the system will give you the patient ID listed on top directly there. And yeah, you will see the CRF. This is a demo, so there's several things we normally show. And the visit is open. You enter a date of visit. This activate the forms. So if you not perform this visit or not do this due to dropout or screening failure, there's no need for entering any information here. And then you simply click through the forms, date of informed consent. You can select any date here from the calendar, or if you do it on the same day, just click today and the date is entered. Go to the next page, date of birth or month and year of birth. It's calculated automatically, the age, gender, and eligibility criteria, yes and no. If yes, everything is fine. If no, we will show a kind of a list of the criteria you selected. Depends on what we develop in the next weeks. We have options with yes and no, or just simply click it. This will be part of the development soon. If there's a laboratory pregnancy test, you can have some leading questions. It will guide you through it. If it's negative, everything is fine. If it's positive, we will have some notes, some information. So you really get guidance through the ECRF and not need to remember, okay, when the test is positive, what I have to do. There will kind of links and guidance for you. As you maybe see, the whole time I click here, I don't press any save or something. But in the system, it's I just show the audit trail. All actions are entered. It's immediately saved and stored in the database. So it's really user-friendly. You don't need to complete the page. There's not a moment that when you enter it and you get a security log out that the data are lost. If you enter it, it's in the database. Here, just some examples for the possibilities here. If you have different answers, we can really guide you through the things. If there's a reason, we ask in a separate field and can show you this. Vital signs, usually the way I use, and you see as soon as I enter the data, there's activities on it. I just generate 2 autoqueries, one heart check, that the systolic blood pressure is higher or equal than the systolic blood pressure, and you see you have no option here. You have really just the information. Okay, you have to do something, and if I change the value here, it's automatic close, and there's no action needed, no confirmation there. On the second, it's a typical soft check. You can click accept and write whatever you want. Best would be a good answer why you think that the heart rate is out of range. Otherwise, you produce requeries, and it could be a bit annoyed if there's too many requeries. But yeah, you see it's really interactive and fast. You don't need to go back and have a separate list of queries. Usually, we have also kind of links to annex or reminders for other forms you have to fill out in the other part of the CRFs, and we could implement a signature on visit level or on page or patient level. So there is the signature form. I think one important part it's here for this trial is the randomization, and if we do a IVS randomization within the system, we have such a form. There will be maybe some leading questions if the and control checks there, but at the end you click on a link like this and the magic happen. You get a date of randomization and the assigned randomization number or the treatment code you need, or the group the patient run into. Some parts are always asked for calculations or for different ways to enter data. If there's a need for a score value and we have the values in, we can do such a calculation in the system, so you don't need to calculate the values and enter the sum. We can have this here in the system, and it's visible and directly accessible for the CRAs and for all. I will show adverse events just as an example here. There's this leading question to start the area, and yeah, we enter just the event. You see the case of the letters is always uppercase, so there's for coding purpose and so on, the way that there's no differentiate between the writing, and the SRE criteria just pop up. If you say it's serious, then you need to answer if it's the known criteria, and here the outcome. If it's recovered, resolved, we ask for the date. If it's not recovered, we not put the date in, so you don't need to enter as an unknown or not applicable. Based on your previous answer, the system will put it in or out. If we go to the concomitant diagnosis, it looks similar, but here we have, due to the amount of information we need, some less information here, and we can just add some minor information. I will say it's from 2000, and I say no, it's not ongoing, and it's stopped 2019. And you see here on this part, it's optional, it's not required a day or month, and it's valid directly. If we now go to the medication, we see that we can enter the medication, we can enter the indication, and I say, okay, this medication was given for the adverse event, and I can select the event here and directly link the medication and the event. So there's for the CRA, for the study nurse or study coordinator, it's directly shown if the date or the range, the start days fit. So it's really help here to enter the data and not to produce double data entry, because you have to enter the indication or the event again. Okay, at the end there is, of course, end of trial form, a signature at the end of the patient. Here is also the system is controlling when it's able to signature. And one of the important parts to make the data entry easier, or the query handling easier, you can simply click failed checks here. You get a list of the queries which are pop up and can directly jump into the form. You see the check and can answer it. So when you not do it directly with data entry and answer this, then you have this way for the quick search to find the task you have to do. Okay, I would end here. If questions for the system or comments, otherwise you will have to see the CRF in some months. You mean for your site, or?
Again, from the experience with the dedicated trial, where we screened a lot of patients and a lot of them, maybe it's worthwhile to do something.
So you see here the overview about one site, and these columns here can be added. There can also be subject status, so that you can say screening failure, randomized, completer, so that you have an overview for the site if this patient is a screen failure or completer or so on. There is, or there will be, for the live trial, there will be separate options, and we can agree to the layout within the development, what we need to show at this part. In many studies, it's usually to show the gender and the age, but I think here maybe other important parts is necessary to show and to make it easier, or the treatment arm, or the arm of the randomization that is directly shown here in the overview.
Normally, we should avoid to have crossovers in terms of procedure, but it's always something that happens during the course of a randomized trial. But we should try to minimize that, because we're gonna lose some patients or create a non-balanced proportion of patients in one arm as compared to the other one. So we should try to avoid that.
Yeah. Okay.
Okay. So thank you very much, Richard.
He will be presenting you his slides about EcoCore Lab, and hopefully we will hear.
And just one, while we are connecting to Philippe, we had a comment about adding as a screening within the screening slide the calcium score. So maybe this is something that is quite easy to achieve if you get a non-CT scan, and it's easy to calculate via the software, or you ask it to the radiologist. So maybe it's certainly it's going to be part of the screening slides when you get the slide deck.
Hello? Can you hear me?
Yes.
Yes. Louder. Good. 1, 2, 1, 2. Rheia trial. Rheia trial. Okay. Excellent. Well, thank you for having me. I'm sorry for not being able to be in person. I'm in Madrid right now, and we'll be back in Canada this afternoon. But I'm very excited about this trial. I think it's a very innovative and important trial. And I'm happy to serve as the core lab director, EcoCore Lab director for this trial. As you know, I'm based in Quebec, so in somewhat still cold part of the world. If you go to the next slide, we're going to cover rapidly the agenda of this presentation. So the first, I would like to spend some time on how we operate as a core lab, what is the workflow in the Echo Core Lab. Then what are the objectives of the echo imaging protocol in the context specifically of the Rheia trial. Then we'll discuss, I don't want to spend too much time, but some of the main points regarding how to prepare examination, positioning, and general procedures. I guess that there are some coordinators, study coordinators in the room, and they may be interested, to know some of the items regarding the core lab and the image acquisition sequence. I won't go through the complete image acquisition sequence. There will be a more detailed PowerPoint and webinar to be provided later. So, and finally, how to transfer the echoes to the Echo Core Lab from the site to the Echo Core Lab. That will be the last point. But this may change because it will depend very much, the protocol will depend very much on which company will be used to do this image transfer. So if we go to the next slide, that should be, you should see a busy algorithm with yellow and blue and green boxes. So the way we work, we are connected to all the participating sites, and the echoes are transferred from the site to the Echo Core Lab, to our server in the Echo Core Lab, using a company, an image transfer provider. We've used so far in the other partner trials that we've done in the past and still doing, an early TAVR and TAVR Unload. We use the BioClinica. I think for this trial we may use a different company, but this is not that important. I mean, the important way is that the echoes are transferred efficiently and not corrupted to the core lab. So that is the first step. And then the second step is we have an initial quality assessment of the echo to make sure that the echoes are complete, well anonymized, and then they are dispatched to our sonographer. We work as batch, so we do actually generally a batch of 12, 15 echoes per batch, and they are transferred to the sonographer. And we all use the same imaging platform, same version. This is the TomTech. We use a TomTech image analysis software. Why? Because it works well with all types of echoes from different vendors. We analyze the echoes in DICOM format, and TomTech is a good and FDA approved, etc. Software. May not be the best, but it works very well for us. So the sonographer will do all the quantitative measurements, the tracing of the gradients, the valve areas, etc. Then the echoes are, with all the measurements and images, are transferred to the cardiologist for overread. So the cardiologist will typically check all the measurements, eventually correct some of the quantitative measurements done by the sonographer, and will do all the qualitative grading. So all the qualitative assessment, the grading in particular of the aortic regurgitation, mitral regurgitation, identification and description of the potential complications are done by the cardiologist. And then we have a last step, that is me. I'm overseeing and double check everything. You know, I'm a kind of a bit obsessive compulsive with the echoes, and I like to have a final look on all the data and everything. And sometimes I do some additional corrections and modifications to justify my salary, I guess. And so this last validation, once it is done, then the echoes are saved in a server and backed up in 2 different servers in 2 different locations with all the measurements. And what we do is we directly enter our measures in an electronic CRF. We don't use any more paper CRF. So typically the sonographer will fill the fields in the ECRF, then the cardiologist check this data and eventually enters new data. And same, I am doing a final check at the end, and then I'm going to lock typically the CRF. And I think you're going to have the presentation on the ECRF next, but the core lab will be one of the ECRF. So if we move to the next slide, and I may go more rapidly on the other aspects because it might be a bit more specific and technical, but what is the objective of the echocardiographic imaging protocol? Of course, this is to obtain an initial echo Doppler examination at baseline to assess the cardiac anatomy and valve function. Of course, we're going to have a particular emphasis on the aortic valve, the left ventricular size and function. And then if we go to the next click, the primary goals of the follow-up, so post-implant studies, post-AVR, is to, of course, assess the valve device, its location, function, and to determine how the AVR impacts the cardiac function. So if we go to the next slide, this is the imaging protocol, and this is the schedule of the echo visit. You should see a small table, and actually the table shows that we're going to collect, in the context of the Rheia trial, we're going to collect the baseline, of course, in all patients, then the discharge echo, essentially for safety purposes, and then the 30-day. 30-day is a very important one because generally the quality of the echo is better. This is the baseline post-implant function that we can assess at 30 days, and then we're going to do the 1 year. The window range acceptable for the that I put here are probably not final. This will be eventually adjusted in the protocol, so stay tuned. I actually put the time window that we generally use for the partner trial. So for the baseline, we allow a 3-month window. So if you do the echo within the 3 months of the intervention, this would be acceptable to us. For the 30-day, we allow a 7 days window around this time, this date of the 30-day date actually, and for 1 year it's a 30 days window. Maybe the 1 year is somewhat strict, but we'll see. So if we go to the next slide, I just want to emphasize the most important thing. We want to use, of course, good state-of-the-art ultrasound system. The only accepted format for the echoes to be sent to the core lab is a DICOM standard digital. I mean, it's pretty standard, but we cannot, of course, read AVI files or native files from the manufacturers. We need the DICOM. And the next click, please. Actually, this is just to show what is the frequency range that is typically accepted, but this is generally standard. So the next slide, you can go on all clicks, please. There are 3 clicks, so we can see the 3 paragraphs. Of course, we would like to have a qualified physician or sonographer to do the ultrasound exam. Ideally, if you can use the same team for the different echoes at baseline and follow-up in a given site, this is always better because there is always a viability related to the sonographer or the person doing the image acquisition. This is not mandatory, but this is ideal. So ideally, same team and also same system. Because if you change, if you go from a GE to a Philips, it might also introduce some viability. This is not mandatory again, but this is best. We can go to the next slide. So one of the things that is important when we do the echo is to have a high quality ECG. I still receive some echoes with no ECG or very low amplitude ECG. ECG is important for us to synchronize our measurements. So please, this is an important thing. There should be no patient personal identifier visible in the header or of the echo file or the images. So we want to be sure that the echoes are well anonymized. Generally, the company that ensures the image transfer also provides to the site a platform that allows anonymization. So this is, of course, a very important thing to protect personal information. And if we go to the next click, generally, I don't know if it's going to work that way, but we of course, we need to identify the echo using a study ID. That will be a labeling of the echo according to the site number, patient number, and visit that will be provided by the coordinating center. So if we go to the next slide, it's kind of busy. You should see two tables. Actually, this is the image acquisition checklist that we will provide to the site. It's a two-page sheet that the sonographer or the cardiologist doing the echo can use to check to make sure that they provide all the views and the signals and images. It looks like a lot, but in fact, you will realize that this is a pretty standard, routine, complete image acquisition that we do for a patient with valvular disease. So there is the parasternal long and short axis, the RV inflow and outflow view, the parasternal short axis, and then the apical 4-chamber, 5-chamber, 2-chamber, 3-chamber views, and then finally the subcostal and all the right parasternal and suprasternal notch views. So, I mean, this is the usual imaging sequence that we use, and there are a few specifics and things that we request in the trial, and I will cover them. And anyway, in the webinars that we'll give for the sites later on, that generally is very well described. So if we go to the next slide, I think one of the important points with regard to assessment of regurgitation in particular, and particular aortic regurgitation, because one of our, of course, objective is to ideally demonstrate very low rate of paravalvular regurgitation in this population with the Sep2019 compared to TAVR. A multi-window imaging is key with color Doppler. So the four main views are presented here: parasternal short axis, long axis, and the apical 5 and 3. But more views we have, more happy we are. And this is for AR, but also for MR. So color Doppler interrogation in multiple views, multiple planes. If we go to the next slide, one view that is extremely important is the parasternal long axis view, with a good view of the left ventricle and a focused view, zoom views on the aortic valve, of course, with 2D, with color Doppler. This is one of the key views where we do the LVOT diameter measurement, which is always a challenging measurement and key to calculate the valve area. If we go to the next slide, this is the apical 4-chamber, which is also extremely important. We need good views, 4-chamber with a zoom views on the left ventricle for assessment of LV ejection fraction and also different parameters that we can measure, especially the right ventricular function. And that's one of the things that we discover with the partner 2 and now even more with the partner 3, I'm sure we'll see in the Rheia trial as well, is that maybe the crux and the most interesting information is from the right ventricle. And when we compare TAVR versus TAVR in partner 3, there was not much difference in terms of recovery of LV function, LV ejection fraction, and even global longitudinal strain. But when you look into the right ventricle, this is where you have a big difference. The RV function is dropping with TAVR, whereas it is relatively well preserved with TAVR. So I want to be sure in this trial that we also collect this information regarding RV function. So apical 4-chamber optimized for the right ventricle is important, and we're going to measure in this trial, as we did in the partner 3, we're going to measure the TAPSIR, but by 2D method, because I realized that when I asked the sites to do the TAPSIR by M mode, in about 50% of the cases, it's missing. Whereas the TAPSE by 2D, I only need the standard 4-chamber view with some optimization for the right ventricle, and I'm able to do this measurement in the vast majority of the patients. So, and it's a reliable parameter that actually predicts mortality in partner 3, as we presented at the late-breaking trial activity. So the next slide, you should be on apical 5-chamber view. Is that right? Maybe if not, well, advanced until you see apical 5-chamber. This is a very important view as well because this is where we're going to assess the AR and, more importantly, measure the velocity in the LVOT. So if we go to the next slide, this is again apical 5-chamber view for prostate valve. Again, the velocity is sampled at 2 levels for the prostate valve, just underneath the stent or steering ring. Yes?
You need to come back, one slide back.
One back.
One back.
Right? And apical 5-chamber view prostate valve, or do you have apical 5-chamber view native valve?
Now we have the, yeah. Okay.
Yeah, I think I forgot to give you the the cue for at least I think the TAPSE by 2D method. I think I forgot. That's why. So you should go over TAPSE and then examination second apical 5-chamber view, native valve, and then you should go to apical 5-chamber prostatic valve.
Yeah.
Okay. Okay. So for this, we're going to ask the site to do sampling of LVOT velocity just below the valve and just in the stent but below the leaflet. This will be well described in the protocol, so no worry. And it is also mentioned in the checklist. So if we go to the next slide, that should be apical 2-chamber view. Same recommendation of 4-chamber. We need a good view zoomed of the left ventricle because this is a view that we use for the biplane Simpson. And LV ejection fraction is always an important parameter, so we want to make sure we have a good 4 and 2-chamber to do the biplane. If we go to the next slide, this is the 3-chamber view. Okay, that's the last of the apical, and it shows here well the 2 sampling of velocity, because the velocity that we do by pulse wave Doppler, we request in 5-chamber, but also in 3-chamber. So we have more signals. We need actually more acquisition we have, and with many beats, not traced is good for us. And so it is shown here what we should do for TAVR and for TAVR in terms of sampling of LVOT velocity. And if we go to the next slide, and that's an important one, that's the right parasternal view. Why is it important? Because in up to 50% of the patients, you will find the maximum transaortic velocity at this right parasternal view and not at the apical views. And many sonographers and cardiologists, they sometimes do the apical views and they forgot to do the right parasternal. So right parasternal is extremely important to acquire. So we are sure that we did not underestimate the gradient at baseline or at follow-up, the aortic gradient. And if you go to the next slide, this is exactly what I mentioned. It's the a study showing that you will find the maximum, the highest peak velocity and gradient, not at the apical chamber, but in the majority of the cases will be a right femoral border, okay? That's a study from the Mayo Clinic, actually. And if we move to the next slide, this is an example that actually I got from a patient who was recruited in early TAVR, and it's the same patient with different views. So my sonographer first said, well, this is not severe, the patient is not eligible for the trial. The velocity was 2.9 meters per second, but this is from the apical view. But she did not at the time interrogate the the right sternal border. And when you look at the right sternal border, the conclusion was much different. The velocity was 4, and then all of a sudden, the patient was asymptomatic because it's for early timer, was eligible for the trial. So I think it's very important to, so I insist a lot when I'm giving the webinars for the sites on this multi-window interrogation with continuous wave Doppler. So if we move to the next slide, this is the last part, how to transfer the echo images to the collab. I don't think, well, this slide is any more relevant because I put the slide that I generally put when we use BioClinica as the provider, but I think we'll use a different provider, so probably it will be a different platform and different template, but generally it's always the same. The site has to enter the identifier of the echo, and there are a few questions generally that are requested, so there is generally a transmittal form that is associated with the echo that will be uploaded. So again, the echo needs to be anonymized and in DICOM format. And if we go to the next slide, we have a quality assessment process. So we actually, for each echo, we look if the echo acquisition was complete, and if there was some missing images or some acquisition that was suboptimal. And we provide feedback to the site. Generally, we do this feedback via the image provider, the image company. We could work differently if you want in this trial. I'm flexible. It needs to be simple process though, and sometimes we have some queries that are more urgent. For example, if sometimes we receive echoes that have been, maybe the file has been corrupted, and so, for example, the video clips are not playing. I have only fixed images. So then I have to go back to the site and say, can you re-upload the echoes, and or do you have any more images? Or so we do a rapid query in this case. So, and then the next slide is just to thank you and know if you have any comment or suggestion or question. Thank you very much.
Thank you very much, Philippe. This was a very described and thorough description of the echo requirements. Personally, I'm not an echo specialist, but I have one simple question for you. You just mentioned that the right parasternal view was one of the best to assess the gradients, the peak velocity. Has it to be repeated during the follow-up once the prosthesis is in place, whether it be a transcatheter or surgical? Do we have to promote the use of that right parasternal view?
So I missed. It's very difficult to hear you. So if someone could repeat the question or the comment close to the microphone or summarize, that would be great.
Thank you. Just here.
Sorry about that.
And now,
I should
do you hear me now? Is it better?
Oh yeah, that's much better. Yeah.
So you just mentioned that the right parasternal view was one of the best to assess the peak velocities and the gradients by continuous Doppler assessment. Does it have to be repeated during the follow-up? Because if it is the best, do we have to promote that view for the assessment of the gradients once the prosthesis is in place, whether it be a TAVI prosthesis or a surgical one?
Yeah, absolutely, absolutely. We need to have systematically this view. So interrogation, especially the apical. So essentially for continuous wave Doppler, the minimum is apical 5-chamber, 3-chamber, and right sternal border. Because I've seen some cases, for example, after implantation, where you think or you say, well, I have the 1-year echo or the 30-day echo and then the 1-year echo, and then the gradient has increased by sometimes 10 millimeters of mercury, and you say, oh my God, you know, it's maybe a subclinical thrombosis or something. But in fact, you realize that this is just due to a difference in imaging. At 30 days, we only had the apical 5-chamber or 3-chamber, no right sternum border, and then at 1 year now you have the right sternum border and you have a higher gradient than the apical. So that's why, yeah, it is indeed very important to be sure that we have this right system on board, not only at baseline, but also at follow-up. And eventually, maybe in the EcoCollab CRF, we should maybe have a checkbox where we indicate which is the view that we use to measure and report the gradient.
Philippe, this is Hélène. Do you hear me?
Bonjour, Hélène.
Bonjour. Could you confirm to the investigators and the coordinators that they will have a kind of booklet, a manual to follow all these rules and to do it properly?
Yes, so there will be several things. Generally, we provide actually three main documents. One, I think, which is the most useful, is similar to what I presented today, but it's a more comprehensive PowerPoint. I already sent it to Peter and Lenka, so it's a real detailed PowerPoint presentation, because when you talk about imaging, it's better to have images to show what we need in terms of acquisition. So I'm covering the complete protocol, the imaging sequences, and the tips and tricks. And I kind of update this PowerPoint presentation, and I think it would be good that this PowerPoint presentation be provided to all the investigators involved in the performing of echoes. There is also the checklist that I showed that I think is useful for the sonographer during the realization of the echo. And we also have a manual where there is more text than in the PowerPoint, and where we actually, again, put a lot of images so it's a kind of a manual of operation for the image acquisition protocol. And of course, I did not mention, but all our measurements are standardized. The image acquisition needs to be standardized, but also our measurements are extremely standardized. So we have, for the CoLab, we have standardized operating procedure, SOP, that we follow, so we all measure or try to measure the same way. But I think this information will not be transmitted to the site because they do not need to do the measurement. What I want to be sure is that they have the complete information for the imaging acquisition protocol.
Do you have any additional comment or question for Philippe?
I will tell him first.
Okay, so we have time if you have anything that you would like to clarify concerning any aspect of the trial. So we try to provide you with all the major information. I'm sure that in the upcoming weeks you will have things that will raise in your minds, concerns that you would like to be addressed. So feel free to directly contact Hélène or myself, Lenka, Yana, Peter, or anyone from the Triple S company. So feel free to reach out to us to discuss any aspect that you would like to get an answer about.
Sorry, Didier? Oh, yeah. Can you tell us something more about the publication policy and the availability of data for other analysis for all the centers?
Yeah. So this is an important point, and the main rule is that the steering committee will decide the policy for publication, and we will decide the rules. It's not only based on the enrollment. It will be based on several factors that we will determine. And for the first paper, we will see how we distribute the centers and things like that. And then if any center has an idea of a subsequent study that you would like to be in charge of, it's open. So you just need to reach out to Hélène, myself, the steering committee, and we will generate a kind of list and see what we can do in the future. It's open. It's not going to be only within the hands of Hélène, myself, or the members of the steering committee. For sure, for the first paper, we will have to lead that. It makes sense, but it's totally open for subsequent papers, definitely. And we want you to come with ideas, because we have a kind of gold mine within our hands, and we have lots of things, lots of learnings to bring out of this.
Why have you excluded TAVI by a non-femoral way? And we won't have this information before the CT scan, so it could be difficult for the inclusion of patients. So why?
It's because the study was based on the results from Partner 3, and Partner 3 it's a TF. So we decided to follow with the subgroup of women, to have a single group. That's the reason.
Yeah, but the event rate would be different. So the study, the power calculation is different. And do you believe that non-femoral accesses are going to be important in the future?
I don't believe. But the carotid artery could be one possibility, and to get those patients, to keep those patients in the study. But, and for example, for a patient with obesity, overweighted patient, surgeons don't like to operate those patients, and we don't like to do femoral artery if overweighted patients, so the carotid artery way could have been an alternative.
Yeah, it's true. It's true. It would have been a good option, but we had to make choices, and if we have to calculate the sample size, we have to base our decision on something. And the low-risk trials were transfemoral TAVI trials, so we decided to stick to that. But maybe in the future, but this is going to be another trial. It's not going to be a Rheia, but I do believe that in the future we will see less and less non-femoral accesses.
But that's true that it will be a selected population of women.
Yeah.
Because radiation, as was said by someone, is of course more common in women, but will be excluded, etc. So.
I'm a study coordinator. In my hospital, the femoral access is assessed by angiography. Is it mandatory to perform it by CT?
So you're coming from Massy?
Yes.
Yeah. Yeah, we will really encourage the investigators to try to get the CT angiogram of the peripheral vasculature, just to provide consistency to the testing and to the data that we acquire. I know that it's not a routine practice in your institution, but I will discuss with the PIs just to get that, at least for the 10 to 20 patients that are going to be included in your centers.
It will be for the radiologist. He will have to complete the CT scan, not only doing heart, but doing the access.
Yeah. No. Anything else? Okay. So it seems that we provided you with all the information, the required information. Personally, I would like to say that I was really and positively impressed by the quality of the discussion that we had, the quality of the interaction, and I hope you felt the same. Hélène, we could feel a kind of already engagement and commitment to this trial, and we really count on you. It's not about our trial, to Hélène and myself, it's our trial all together as a group of centers, a group of investigators. So we really ask you to take it as if it was your baby, and to really make sure that you're going to select the proper patient, make sure that everything is done the right way, so as to make sure that we don't have deviations, and we collect the most efficient, the most optimal data for this group of patients, because it's a quite unique trial. It's the randomized trial, it's the female, a gender-based trial. It's a European trial. We have to be proud of that, because it wasn't so frequent lately. So we have something that is valuable, that is going to improve our knowledge altogether. And so my what I really wait from you is that you take it as if it was your trial, and locally, as local PIs, as study coordinators, as echocardiographers, you really make sure that we collect the appropriate things for these patients, and even we double pay attention to these patients to make sure that we catch everything we can, because there is a lot more to come. We have discussed about the subsequent studies that we can do. I'm sure that if we collect as much data, as much high quality data that we have, we're going to get a lot of papers, and everybody is going to be involved, and we will provide a lot of information to the medical community.
I think his short conclusion was absolutely perfect. So I don't think I have something to add, just to thank all of you for having been here and participated to this important meeting to understand the importance of the trial. And it was nice to meet with all of you, to get in touch with some of you I never met. So I think thank you again, and let's start.
Yeah, exactly. Thank you.